A very good evening to one and all of you.
Recording in progress.
We are back to you after a short break after the AIOS, and I'm sure there's going to be a great set of webinars which we have lined up for you over the coming year with the best of speakers and an amazing expert panel. And I think there would be a whole new range of discussions which are going to come up in the ensuing talks. I'm most thankful to our Dr. Namrata Sharma, who's, I'm sure, so very popular and known to one and all of us, Professor of RP Center, Cataract, Cornea and Refractive Surgery, and also the amazing Honorary Secretary of AIOS. Joining us soon will be Dr. Kumar Doctor, who's Director of the Striae Institute from Dehradun, again, a very leading cataract refractive surgeon and Chairman IARSA. Joining us soon will be Dr. Ramurthy, who is the Chairman of the Eye Foundation Group of Hospitals and our past President AIOS. Joined us, thankfully, is Dr. Mahipal Sachdev. I'm sure I don't even need to introduce an amazing individual that he is, the Chairman and Medical Director of the Center for Sight Group of Hospitals, and of course, our amazing past President of AIOS. With us is again another amazing figure of cataract and refractive surgery with a great national international presence, Dr. Jeevan Titiyal, who heads the RP Center of All India Institute of Medical Science. And I'm sure there's going to be so much of learning which we are going to have from him. With us again is a very dynamic, versatile Dr. Kumar Doctor, who is the CEO of the Dr. Eye Institute, Mumbai, another great specialist in cataract and refractive surgery and a pioneer of many procedures in the field of ophthalmology. Joining us soon is Dr. Thind, who is the founder, chairman, cum medical director of the Thind Eye Institute Hospital. Again, a very known figure in all over the country and more so in the northern side for his amazing numbers and versatility in surgery. Moderating with me is Dr. Anaga Harur, who is the medical director of Anil Eye Hospital. Again, a very versatile surgeon and member ARC West. And the other person is Dr. Satyajit Sinha, who is yet to join, who is another member ARC East, a strong participant and the chairman of the ABI Institute. And I think we shall, without delay, go on to our first speaker. So we have with us taking the lead role is now Dr. Ritin Goel, who is a cornea and anterior segment surgeon from Goel Eye Institute, Delhi. And he is going to set the ball rolling with a very important talk of the present day. How would I do my topo-guided planning in regular corneas? On to you, Dr. Ritin. Could you share your screen?
Thank you, Dr. Chitra, for the kind introduction. And thank you, ma'am, for giving me this opportunity. I hope my slides are visible.
Yeah.
And I'm audible.
Yes.
Okay, so thank you. And I'm going to start, I'm going to talk about this topic about topography guided ablation in a normal cornea. In the current age, we are doing a lot of refractive surgery. Everyone's doing a lot of refractive surgery in the OPD. I'm sure all your patients are asking about Contura Vision. Contura Vision is essentially Alcon's name for topography guided ablation in a normal cornea. And I'm in this presentation going to talk about how I do the planning for these procedures.
You have yours next, yeah.
So I have no financial disclosures to make at this point. I'm an Alcon EX500 user, and my talk will be especially relevant for other Alcon EX500 users, but the principles are the same if we try to look at other platforms that have the same flying spot technology and the topography link. So the 4 P's that my presentation is going to cover is the principle of the procedure. What is the potential of this technology? How do we do the planning? And what is the root cause, what is the main problem in this planning? And what is my solution to that problem? So if we go on to the procedure, to the principle of the procedure, it's very simple, just like any refractive surgery. We have a patient with existing case or anterior corneal curvature. We're going to do an ablation in their eye, and we are targeting E, which is emetropia. So in this equation, rather than doing just a refractive correction, we are also adding topography guided ablation unit. So A is refractive ablation and TG is the topo guided ablation, and we're going to do it together. Now, just to understand why is this topography guided ablation important, or whether it makes any sense, or is it a marketing gimmick, I'm going to take a irregular cornea. The reason for taking an irregular cornea is, on a lighter note, if you would to look at an advertisement of a detergent, you can only find out if it works if you have a dirty cloth to start with. So if you look at an irregular case here, you can see that the patient has significant inferior steepening on anterior sagittal curvature maps. This sort of inferior steepening you would see in cases of keratoconus. On this, we are doing a topo-guided ablation, and these are the kind of results that we can get. So if you have a cornea that is quite irregular, you could subtract some amount of corneal tissue from it, and you could make a regular shaped corneal anterior surface. With this idea, if we could use this in refractive surgery, where we are anyway shaving off some corneal tissue for refractive correction, could we make a normal cornea even better? So that's the idea. So how do we do the planning? We take our patients' preoperative data like the pentacam, and we know their anterior corneal curvature. The next thing we want to do is refract these patients. After a good refraction, we have the ablation profile. If you look at this ablation profile, it's nothing new. It's a simple myopic ablation. We do a good topography of this patient, multiple repeated topographies with a topolizer, and we get the machine to suggest the minimum topographic ablation that it needs to do to regularize this cornea. This is an automatic feature of the machine, and this is based on the Zernike analysis of the cornea. But without throwing too many technical terms, to make it really simple, the anterior surface of the cornea has some undulations. This ablation profile is looking to smoothen out those irregularities. If you look at the ablation depth, the topography guided part where we are only regularizing is hardly ablating 8 to 9 microns, whereas the total number where we're doing the refractive correction, that's where the bulk of the ablation is going. So the treatment is actually done as a single combined procedure, and this is what the ablation profile looks like. So what's the problem? The problem is that we've been doing refractive surgery, laser refractive surgery, for last 20-25 years, maybe or nearing now 30 years. And ablative refractive surgery has had excellent results. It is probably one of the most best accepted surgeries in the world. The results are marvelous. What we've been doing is we do a good subjective refraction of our patients, and we get excellent results. Now the problem is, if we are going to do that, and to that we're going to add some topographic ablation, I'm sure you and I were both thinking this topographic ablation is going to have a refractive bearing as well. So when we were targeting emetropia with our original refraction, if we are going to add topographic ablation to it, for sure we're going to miss the mark. So what's my solution to this problem? I look at this topographic ablation first, even before doing refraction. I look at what is the difference between the center of this ablation and in the periphery. So if you can make out the center is about 4.5 microns, that's the ablation, and the ablation in the periphery is going to be around 8.5 microns. The difference is just about 4 microns or 3.9 microns in this case. If I was to extrapolate this and change this ablation pattern to something more regular, it would look kind of like a hyperopic ablation. With a 0.25 diopter of hyperopic ablation, we would be treating around 3.9 microns in the periphery. If I try to extrapolate this a little further, it would look like a 0.25 cylindrical ablation, which is also a hyperopic cylinder ablation. Here too, the max ablation would be 3.9. Considering that if I would add the two, it would be very high. Let's take half of both, and let's take it that the net effect of this this topographic ablation would have a refractive effect of plus 1.12 diopter sphere and plus 0.12 diopter cylinder. Now the refractive ablation being as it is, we know that the topographic ablation is going to do some hyperopic treatment. My suggestion is just convert this entire hyperopic treatment into a sphere and treat your myopia just that little bit more. So 0.18 diopters extra in this case would be what I would apply for my final ablation treatment. So just to summarize, we will take the two of these, combine it into a single one, and this is the treatment that I would do. And so far, my results have been pretty good, and I've been quite happy with this idea. So my 2 cents about this procedure and the way that I'm doing it is do your topography before doing a subjective refraction. Make sure that you are either under or overcorrecting the sill by less than 0.25 only. So say if your patient is accepting 1 diopter of sill and you're seeing that your topographic ablation is also going to treat about 0.25 of cylinder in the same axis, you can sort of undercorrect the sill a little bit. And if it's going to treat it in the opposite axis, you can overcorrect. Adjust the additional cylinder and topo ablation in the spherical correction. If you don't want to deal with the cylinder, just change the whole thing into spherical and treat that. And my suggestion is do the refraction yourself.
Thank you, Dr. Goel. Can you stop sharing your screen if you're done?
Yeah. Thank you. I would do that. Thank you.
Thank you, Dr. Goel, for splitting the understanding of topo-guided regularization along with refractive correction in your own logical way. But it could be approached even more simplistically than that too. Just a question, I'll start with Dr. Titiyal. What would you do, doctor, if you have your topo axis and manifest axis are not aligned? Would you still do a contour treatment or would you do a wavefront guided treatment? Dr. Titiyal? He's not there.
Is not there.
Dr. Namrata?
Yeah, I think Chitra, if they are not aligned with each other, then I think I would go in for a wavefront guided and not go in for a topo guided treatment.
What we have understood, Namrata, I'm sure you would agree with me, is that if the topo axis and the manifest axis mostly would align in a normal cornea, but if they're not aligned, we would recheck the refraction, we would ensure that the topographic maps are ideally taken. But what we've understood is that if we use a manifest refraction and do a contour treatment, it works well in these one-off situations, and it has been consistently all right. So anybody else, Dr. Ritin, would you have anything to comment on that?
So ma'am, the point of my presentation exactly is that Alcon in 2016, when they got FDA approval for their contour treatment, they were working very hard in ensuring that the manifest axis is coming very close to the measured topographic axis. Now my point is that when the manifest axis is very close to the topographic axis, these are normal corneas that don't have irregularity. So we're taking a regular cornea and trying to make it more regular. The point of a regularization treatment is going to be more important when they actually don't match. So my whole idea of telling you this, that let's convert it into a sphere, because these are normal corneas, the total magnitude of the spherical change that we'll be making is very small. Treat your refractive, go ahead with your refractive treatment as per your subjective refraction. Whatever topo regularization you're doing, just convert it into a sphere. This principle we were following for contact lens prescription 40 years ago, when we didn't have toric contact lenses. That's the time when we were talking about first order aberration and second order aberration cylinder, which we didn't have. Now we're talking about third and fourth order aberrations. It's not going to make a big difference. If we just convert that minute part into a sphere, I think we'll have good results, and that's my idea.
And what I also understand, I might conclude this, but if anybody in the expert audience would want to add, they are welcome.
Can I say something?
Who's that?
Kumar?
Yes, Kumar.
So I understood whatever you said in your presentation, that you converted to the spherical component. The difference was 0.18. Question here is very simple. You are saying that each one showed a board that next day I'm 6 by 5. If you are treated 5 and not the 0.18, he would still not be 6 by 6?
He is 6 by 6.
He will be 6 by 6.
He will be.
So
I'm
what is the clinical significance of this 0.18 which you want to market, is my question. How much is clinically significant to the quality of vision to the patient? So do you have any studies on that? Because 0.18, according to me, is very difficult to measure clinically, and the patient will not be able to appreciate the value of vision that he or she is getting.
There is one argument for what you're saying too, but incidentally, all these patients have consistently done well. So whether I break it up into piecemeal the way Dr. Ritin did, but definitely one important message for the audience is
the irregular cornea, Chitra, I completely agree. There is no dispute. I'm talking of every normal cornea to do this and to have a clinical significance where the patient appreciates. Then you should have a study where one eye you do that, other eye you do not do contura, and then see the difference in quality of vision.
Yes, there have been studies which have come forward. I'm not able to name them at this point of time, which have said it is favorable. It is not mind-blowing. Maybe one important thing we should take from this is that to an extent all of these products are oversell, then an oversell is being done. But if there is a very significant higher order aberration, if you see lot of coma and trefoil which does not correlate with your subjective refraction, those are cases where you should not do a contour treatment. We need not be as strict as the FDA trial by only comparing it with extremely normal eyes. But if there is a difference in the manifest refraction and the topo axis, you could still go ahead with the manifest refraction axis and do a great job of contour in these cases, is how I have understood, and I'm sure many of us would agree. I think Dr. Shreyas has not joined in.
Yeah, no, I would just like to comment on this. Am I audible?
Yes.
A very nice presentation, Ritin, and I think I agree with your conclusions in the sense that basically what we are doing today, we went through all these recommendations of Alcon, then tried 4 cities, etc. What we simply do is to get the manifest refraction, get the topolizer values as far as the higher order aberrations are concerned, combine these two together and go ahead and treat these eyes. And we find that the results are quite consistent. It is not just in our own experience. There's been a very large study conducted in Germany, a retrospective analysis, multicentric analysis, where more than 30,000 eyes were analyzed. Where they found was, even when there was a very large difference between the topographic axis and the manifest axis, if they took the manifest axis, just combined it simply with the higher order aberrations and treated, these patients did quite well. As regards to Kumar's specific query about whether these 18 microns is going to make a difference, is here we are not talking about correcting refractive error, but we are talking about correcting higher order aberrations in a so-called normal cornea. So the very fact, by definition, the normal cornea is not expected to have too much of coma or trefoil. Yes. We are just trying to address those small aberrations and give a value addition to the patient beyond doing a wavefront optimized treatment. So basically, a contour treatment is nothing else but a wavefront optimized with a topo-guided ablation put together. The wavefront optimized is essentially given by the amount of refractive error that's corrected, and the topo-guided ablation takes care of the small amount of aberration that's there on a so-called normal cornea, and this additively translates into a not only correction of the refractive error but also a better quality of vision.
Yes. Thank
Dr.
you.
Chitra, can I, Dr. Chitra, one second.
Yes, Gaurav. Yes, Gaurav.
Okay, yeah. So I think Ritin explained very nicely what we typically were doing with Alcon contour treatments for the last 5 years with C4, C12 compensation for the refractive result, which was being induced by the, topography guided part of it, and which Forcides does beautifully on its own, and you don't have to waste time on doing all that.
Yes, all this.
Forcides does it for you very nicely, and we use that. So we must do that compensation. Sometimes it will be significant and sometimes not.
I don't think for C4, C12 compensation necessary for a normal cornea, Gaurav. I mean, I would absolutely agree with you if you are doing it for a topo-guided ablation for an abnormal irregular cornea. But
so most often, sir, in a normal cornea, the compensation will not be required much. I mean, you just need to look at those, and if it's a normal cornea, you probably won't need to do it anyway. But Forcides beautifully does it for you, and you don't have to waste time, and put your mind to it. It works really well.
No, Dr. Ritin just made it a more joyous learning for us. That's all. Thanks,
I was just trying to explain how Forcides calculates what it does.
Yes.
Absolutely, very nicely.
And just one small point to answer Dr. Gaurav, to answer Dr. Kumar, Doctor. Sir, I am not saying that this is the best treatment in the world. A lot of our patients without contour vision have excellent 6665 vision. I am just saying that this is the technology. This is how the technology has gotten better. LASIK was excellent 20 years ago. We don't have much scope of improvement, but this is definitely a step in the right direction, is what I believe, in my opinion.
Yes. Thank you, Dr. Ritin. We stay on with us. We shall now go on to our next speaker, Dr. Natasha Pahuja, who is the Chief of the Cornea and Refractive Department at Natasha Eye Care, based at Pune, and she's going to talk to us a very important topic and quite complex. How do I do topo-guided planning in irregular corneas? On to you, Dr. Natasha. I think, are you unmuted?
Can you hear me?
Yeah, we can.
Okay.
Not see your slide though.
One second. At the outset, I would like to thank Chitra ma'am and the ARC committee for giving me this extremely humbling opportunity. Dr. Ritin has made my job so much easier, and I'm just going to take a leap forward and look at what the irregular corneas can do. Now, what are we essentially looking at when we're doing topo-guided corrections? Is if this is an irregular cornea, we are basically recontouring the surface. Now, the patients that are coming to us are getting demanding by the day. Be it a keratoconus patient or a post-refractive surgery patient, they come to us asking, "Aapke paas contura hai kya?" So basically, contura is synonym to topo-guided ablation. But how do we apply it in irregular corneas, and who are the ideal candidates? Now, the irregular corneas specifically are a gamut of patients that can come to us. Most importantly, we're going to look at the most common presentations, which is zone enlargement or a decentered ablation, keratoconus patients, and of course, post-LASIK ectasia. Now, what do we essentially look for when we're looking at a topo-guided ablation? Patients who are ideal for it are patients who do not have a good contact lens fit, are looking for better quality of vision, have got enough pachymetry to spare, and most importantly, are of the right age. But the most important aspect of a topo-guided ablation is that the patients should have extremely realistic expectations. And they have to understand that they may need glasses after the laser ablation as well. So what are we basically looking at? In the next 8 minutes, we're going to justify, is this possible for irregular corneas like this? So the machines that are available that can provide a topo-guided ablation are such. I'm going to concentrate on two machines, which is Wavelite and Schwinn-Damiris. Starting with the Schwinn-Damiris, what essentially is topo-guided ablation is just very simply, as has been mentioned by Dr. Goel, is normalization or neutralization or smoothing. You can call it anything that you want. Basically, we are recontouring the surface to make it slightly more smoother. How does this work? Now, let's take it step by step. And how do I do it? There are very simple things. The things that we need is one, a refraction. a topography, pachymetry. These are absolute essentials when you're planning a topo-guided treatment for an irregular cornea. And let's see how do we plan this and the applications. Refraction, most important is a subjective acceptance. Like Dr. Goyal said, you have to refract these patients yourself. What I essentially do is I ask two of my other optometrists, senior optometrists, to also do the refraction and we verify our results amongst each other before the patient is taken up for refractive correction. Most importantly, I also compare with the refraction that I get from the topography machine as well. This basically comes from the ray tracing method. So it measures the wavefront aberrations and gives us a refraction. So it is a good idea to compare the subjective acceptance with the topography refraction. What Schwind Amaris or the Schwind Cirrus also does is it gives you a small option of putting in the subjective acceptance and comparing with what the machine gives us. Coming to topography, it's absolutely essential to get the right scan. Now, this is a format that we usually get, and this is what we get. But most importantly, the acquisition quality is what needs to be checked before the topography is accepted for ablation. Now, I do the topography myself if the patient is taking up for surgery. What I essentially do is the red cross has to coincide with the Purkinje image. That means the surface topography has been taken correctly. Most importantly, I also look at the Myers. The Myers don't have to be distorted owing to the tear film. The distortion can come from the irregular cornea, but not because of the tear film. I also look at the statistics of how much is the coverage of the placido ring. Is the right amount of data taken up for the refractive correction or the topo-guided correction. Third and the most important aspect is the pachymetry and calculating the residual stromal thickness. Now, if it is a biomechanically weaker cornea, I would keep the RST as to 400. But if it is a normal cornea, like a post-LASIK, which is having a zone enlargement, we can go up to, we can have an RST of more than 300. Depending on the pachymetry that we have, we can decide as to how much amount of sphere or cylindrical correction can be done. Most importantly, a biomechanical weaker cornea has to be enhanced with cross-linking. Now, coming to the treatment planning. I'm going to take two cases and which is going to probably summarize the whole treatment planning itself. Case one is a post-PRK patient who had HSV keratitis 12 years back, has got a scar which is causing flattening in the superior nasal quadrant, and of course a keratoconus patient. Now, a patient who had topography like this, patient specifically came who has not been wearing glasses, came with glare and distortion of vision and has decreased vision. The subjective acceptance is such. Topography acceptance is the cylindrical acceptance, that means matching the topo refraction. Also, the thinnest pachy is 520, so I have enough pachy to do the topo guided ablation. I did it on the Schwind Amaris. I went to the ORK cam. This is where the corneal wavefront correction happens. So what I essentially do is put the manifest refraction as 0 and look at the ablation profile. Now you have to do it in the PRK mode, because if you do the trans PRK mode, then the ablation profile is just red all over and you do not see the subtle changes that can be picked up in an ablation profile. After that, the treatment is obviously done in the trans PRK profile. Now this is the ablation profile that we got. Now if you look at the ablation profile, we see a maximum ablation of 77. That is quite a lot, but the cornea and the biomechanics was good, so we went ahead and just did the 0 refraction. And if you look at this, it compensates really well. It is a very good contouring that is happening. So this is what we went ahead with. What was very, very encouraging was that the patient came back with a topography which looked like what the patient had before the scar. So it is a very good post-operative case that we example that suggests that not only the unaided vision improves, but also with a small refractive correction, the aided vision can also improve. Coming to the next case, which is the keratoconus case, which is the most common application of topo-guided correction. Now, this is a patient who had a subjective refraction of a -3.5 cylinder, but a topo refraction was almost up to -6. But I do not have enough pachymetry to obviously correct all of it. So I went ahead and looked at how much is the total ablation, which went up to the magnitude of 65. Now, of course, after removing the epithelium and doing cross-linking, 65 was sounding a little too much. And this is how the profile looked like. So in this case, I went ahead and did what Professor Shetty has published, which is called as a TREK, as topo-guided removal of epithelium, but it also knocks off the cone a little bit. Now let's see how is this newer application coming into being and how do we plan it. Now we basically take the short axis and measure the long axis, and we see where is the intersection point. Now this intersection point, all these data is measured and it is simply put in the PTK cam mode. Now what we do essentially in the PTK cam mode is the long axis, what we have measured is put here along with the axis, along with the short axis, the automatic axis, the opposite axis comes automatically, and the radius of offset, that is the star mark that we mentioned, that is basically the intersection of both the axes. Now essentially we have to make sure that the trans PTK mode is off and the pachymetry or the ablation that we do is 70 microns. Now this is how the small ablation looks like. So instead of us having a 67 or ablation, the final ablation that we get is 71, which is including the epithelium. So the epithelium that we measured on the pachymetry, on the epithelial mapping was 50. So essentially what we are ablating is just 21 microns as opposed to 65 microns in the topo-guided ablation. So this is what the complete ablation profile looks like. It completely knocks off the cone and makes the cornea slightly more smoother. Now this is a validation of what I was just trying to explain. So the pre-op topography, which is showing a steep cornea, has flattened after TREC, and which was very, very encouraging in terms of the outcome in terms of the visual outcome of the patient. So the uncorrected visual acuity of this patient had improved to 6.9. This is another example where the comparative map shows that there has been almost 6 diopters of flattening with just 30 microns of knocking off. Most importantly, we also looked at the sagittal maps. The sagittal maps, the ablation looks much like how a topography guided ablation or a topo guided ablation what an Alcon would or Wavelight would do. This is done by TREC. So what I'm essentially trying to say is that this is also a very good tissue sparing topo guided ablation, essentially removal of epithelium, but it knocks off some amount of stroma as well, making the cornea slightly more regular. Coming to the Wavelight, we have published this paper. It was called the Q protocol. And this is a very simple protocol. It is based on the corneal sphericity. Now, if we have a Q which is more than -1, along with the C4, C12 compensation that has been already explained, if the Q is more than -1, the Q is not changed. If the Q is less than -1, the Q is not changed. If it is more than -1, it is changed to a slightly more bearable Q, if I could put it that way. And of course, based on the pachymetry that we have, we correct the amount of sphere based on the residual stromal thickness that we get essentially. So what I'm trying to essentially say by this is that by a topography guided, even with zero refraction, we can get very encouraging results. And of course, these patients have to be subjected to a contact lens or a glass prescription post cross-linking. So the question to summarize is it really possible for irregular cornea's vision like this? It is possible, of course, with adjuvant methods like glasses or contact lenses after. Thank you very much for your kind attention.
Thanks a lot, Natasha. That was a very useful information which you did give us. But with the 458 cornea, of course, we do not have Schwinn. We would have confidently gone ahead and done a topo-guided regularization because we still have enough tissue to remove. Now, supposing you are stuck, you had 458 corneal thickness. Supposing you are stuck with a 435 or a 440 and you don't have facility to do TREC and you don't have access to Schwinn. So I have understood, I would want my expert panel to correct me whenever. What I have understood is I can actually bring down my optic zone from 6 millimeters to 5.5 millimeter, which would guzzle up less tissue. The other thing we can do is we can add a little bit of hyperopic correction in our refraction. That again, when you enter it, you realize that little less of the tissue is being guzzled up, but at the same time, topographic regularization is done. But I do understand that TREC is another beautiful way wherein you've just removed 20-25 micron and you have still gone ahead and regularized the cornea. But here, no, by doing a topo-guided regularization on our the Alcon platform, we are able to do some amount of refractive correction too, and then give them a better quality of vision. Dr. Gaurav, Dr. Ramurthy, anybody who, Dr. Tityal, any of you are using these machines, have any thoughts to add?
So even I wanted to ask Natasha the same thing. If you don't have a Schwinn machine, I mean, I'm sure Trek is not possible on other machines. So
Yeah.
what would be your take on it? And have you compared doing Trek vis-a-vis doing on the Schwinn machine with other machines also?
So, ma'am, I have done one eye Schwinn and one eye, basically a topo-guided, a corneal wavefront, which is akin to a topo-guided correction of wavelight. So, a corneal wavefront correction on Schwinn, which had enough Paki to spare, which was 470. I did a topo-guided correction and in one eye, and did a Trek in the other eye, which had a pachymetry of 440. Quite honestly, ma'am, the results are almost the same. But of course, the eye which had 440 pachymetry was already an advanced cone. So in terms of, if you ask me in terms of visual acuity, they're not comparable. But just aesthetically looking at the topography correction is quite encouraging.
Dr. Gaurav, you want to add something?
Yes, ma'am, I think basically Trek, how it is different from what topography guided on Alcon platform is that it works on a very small decentered zone. So Trek is basically trying to just flatten the kind of cone a little bit. That's why you get away with just doing about 10, 15, 20 microns, because you're not really addressing the whole topography and you're decentering it to just kind of fire on the cone itself. Whereas a full topographic ablation, as happens on the Alcon platform, is that it's also trying to kind of raise some areas and like press the cone and kind of making it the cornea more. So the optical zone on a topography guided treatment is much, much bigger. Whereas on Trek, you are essentially doing a very small zone decentered ablation to kind of flatten the cone a little bit. And that's, I think, when you are really short of tissue, that's probably the better way to do it, because you are not going to be able to do much. You probably won't be able to treat them on the topo-guided Alcon platform at all. You won't have enough tissue.
Yeah. No, but on an Alcon platform, sometimes you enter it as zero refraction and you regularize it. Then if you see that the tissue consumption is less, I still feel that I would opt for that as against Trek, and I would look Trek for even thinner corneas when I can't do a topographic regularization, and would I do just a CXL or Trek? Then I think Trek has a role to play in that. Would you agree on that score, Natasha?
Absolutely, ma'am.
Yeah.
Depending on, of course, the more advanced the cases go, you would hold yourself back from ablating the cornea.
Yeah.
But like you rightly said, if there's enough pachymetry, you would choose Trek over topo-guided in advanced cases.
Yeah. So anybody to add? Shall we go on to our third speaker? There are a whole lot of talks ahead. We have with us Dr. Sujata Mohan. I'm sure many of the other expert panel can join in, because we are going on to something which is so critical on a surgical plane. So she is again the additional director of Rajan Eye Care Hospital, a specialist in cataract, cornea and refractive surgery, an amazing surgeon who has performed innumerable eye transplants, and she is going to tell us in her very interesting video, which has won awards, how I would treat flap striae. On to you, Sujata.
Are you able to see it?
No.
Okay. No?
It's a blank screen.
Now you're getting it?
No. Would you stop sharing and share it again? We'll see. That time it came, no?
Yeah. Okay, I've got it now. I think. Are you getting it?
Oh, click and see.
I think we are coming on whiteboard. Because I think the whiteboard, Sujata, the video is not sharing.
Okay. Not sharing.
Sujata, you try once more, otherwise you. Now it's there.
Okay.
Yes, Sujata, go ahead.
Okay.
You have to play it.
Click.
Thank you,
Click on that.
Chitra, for the opportunity. And just the authors have no financial interest in any of the products mentioned in this video. flap striae are defined as small wrinkles or fold in the cornea as a result of LASIK surgery. The most common classification of flap striae divides them broadly based on their size. Microstriae are microscopic superficial wrinkles that are generally asymptomatic and often only detectable on microscopic examination of the cornea. However, macrostriae are larger and full thickness folds that usually cause noticeable visual impairment. The incidence of clinically significant striae requiring treatment is between 0.2 to 1.5%. The common causes of striae are thinner flaps, higher ablation depth, misalignment of flap after replacement, flap contraction and desiccation during ablation, flap wrinkling during stretching, movement of the flap on the first post-op day, tenting of corneal flap over an ablated stromal bed, a nasal versus a superior hinge, and excessive manipulation of the flap. Micro or macro striae not causing visual symptoms can be left alone. Flap folds such as this can cause severe visual symptoms and have to be dealt with immediately. Visual symptoms linked to striae include irregular astigmatism, optical aberrations, monocular diplopia, and degraded uncorrected visual acuity and best corrected visual acuity. Early intervention is recommended in these cases. In the first case, the pupil is dilated for a good transillumination effect on the striae. The flap margins are identified. The Sinskey hook is used to break the epithelium. The flap is lifted and floated on the bed. Two dry merosal sponges are used to stretch the striae perpendicular to its direction. The stretching is done repeatedly till the visual axis is clear. Flap is replaced meticulously and a bandage contact lens is applied. The post-operative photo shows a clearing of the macrostriae with significant visual improvement. The second case presented on the third post-op day with flap slippage and flap folds. Here, the stromal bed is exposed with epithelial ingrowth. In this situation, the epithelium over the exposed bed is meticulously removed with a hockey stick knife before lifting the flap. The flap is lifted. The folds in the flap can be best addressed only by removal of epithelium on the surface. So the epithelium is completely removed on the flap surface as well. The flap folds are stretched using two dry merosal sponges. The bed is washed to remove epithelial nests. Flap is replaced and smoothened with a wet sponge. Four 11-0 nylon sutures and one 10-0 nylon suture was applied to keep the flap in position. Then a bandage contact lens is placed. This case highlights the importance of preventing epithelial ingrowth in such situations. The post-operative picture shows a smooth flap with a good return of visual acuity. The third case shows a similar situation with a flap slippage with dense flap folds and epithelial ingrowth. A merosal sponge is used to completely remove all epithelium on the exposed stromal surface and a 2 mm margin around the flap. Flap is floated into position. The epithelium on the surface is also removed to facilitate the removal of striae. Stretching the striae is done using two dry merosal sponges perpendicular to the direction of the striae. Flap is replaced after completely washing the interface. Fourth case shows a completely displaced flap with rolled edges. This video shows the importance of removing epithelium under the surface of the flap in addition to the stromal bed. The rolled up flap edges are gently scraped off the epithelial ingrowth and replaced. Suturing the flap is mandatory in this situation to prevent repeat flap slippage and epithelial ingrowth. Femtoflaps show less incidence of flap displacement and striae due to better fitting of the flap on the bed. However, this femtoflap shows radiating flap striae originating from the hinge. The epithelium of the striae is removed after lifting the flap. The striae are stretched perpendicularly. The flap is replaced on the bed after thorough washing of the interface. The pre-placed marks show a significant shift after realignment of the flap. In cases with visually significant striae, early intervention, meticulous removal of epithelium from stroma, application of suture and bandage contact lens gives best results. Our series of patients improved with simple stretching of the striae using dry merosal sponges. In case of refractory striae, PTK and Dornenfeld method of hyperthermic ironing of the flap using heated spatulas has also been recommended. Flap striae are better prevented than managed. Examination of the flap at 20 minutes post-operatively is recommended to ensure the flap has not slipped out of position. Careful and precise positioning intra-op is mandatory. Good counseling and need for adequate protection during day and night prevents and lowers the incidence of flap striae.
Thanks, Sujata. That was a wonderful video, and I think it just explained it all, and amazing skills. Now I would take questions from the expert panel, and Sujata, you could add on because you've told it all. Have any of you, maybe Dr. Mahipal, I would ask, would you have thought of trying a PTK for flap striae? And if we were to do a PTK, theoretically, if we were to do it, how would we titrate the amount of epithelium removal? Would we take ASOCT guidance? And
anyway, thank you very much. I have never done a PTK for flat striae removal. I personally feel that the first thing is that if a patient is coming with visual symptoms, often we ignore the patient and say, okay, there is nothing. It's always better to do a full dilatation and do a retroillumination to get these striae into play and to see as to how exactly these striae are, whether they are in the center or not. Recalculated striae, even managed, I have managed a similar bad striae like Sujata showed 1.5 years after the initial thing, having had a wash done elsewhere. The only important thing that I am trying to re-emphasize what Sujata said is that epithelium needs to be removed. The other important thing which I think maybe Dr. Sujata didn't emphasize is the use of hypoosmolar solution. So if you use this thing, that swells up the cornea and it is much easier for the striae to go off, and I fully agree with her regarding using 2 merosal sponges. That will take care. But one important thing is that the striae on the table never disappear. Like you can, you will still see the striae there, but doing the hypotonic after removal of the epithelium and you have to be very patient, and you have to do it for a couple of minutes to be able to say as to what it is. PTK, obviously, I have never needed to do it because the striae go off. And another important thing that Dr. Sujata emphasized was that the incidence of epithelial ingrowth are much higher whenever you relift a flap, and specifically once the epithelium is denuded and you have swollen up, obviously the flap gets swollen up. So at times, if it is very significant, I would prefer to apply a little bit of a glue and then put a bandage contact lens. So
and
these
also,
the things, and epithelium, obviously you have to do an OCT to put it as to how much of epithelium you have to remove, and then remove the stria. But doing a PTK with long stria doesn't really, it's not required actually. You will be able
Actually, probably it does the work of manual epithelial debridement, which we do to a large extent. And I think also removing epithelium beyond the area of flap margin, which is suggested, is one more important point so that the epithelial ingrowth doesn't come in. Any of the other expert panel would like to add?
Can I say something?
Yes, Kumar.
So one thing, Sujata, excellent video. Only thing was that in today's era, we would like to do, if sometimes, these are referred patients, to do an OCT cornea to know the thickness of the flap. Because once you remove the epithelium, suppose you have a 90 micron flap and you have a 60 or 50 micron epithelium, you have a very, very thin flap. Then the whole game changes completely, and you have to be very, very careful when we are stretching with the two sponges. So as rightly said, the sponges, and as rightly said by Mahipal, but I feel that an OCT cornea would help us to know the thickness of the flap, and then we become a little more careful in such cases, because sometimes they are old operated cases, they come back and we really don't remember the thickness.
Swelling of the flap also definitely adds to it and is an advantage. That is why they keep saying to hydrate the flap. But have any of you ever done something as drastic as considering sacrificing a flap if there's really recalcitrant striae and crumpled flap, like after in some kind of a road traffic accident? Dr. Titial or Dr. Namrata, have you all ever felt that you have?
I think
no, I shall be covering that topic towards the end,
Sir is going to show some of the very recalcitrant cases.
I think one point I like to add what Dr. Sujata nicely showed. Like I'll remove the epithelium, debride the epithelium before lift the flap.
Yes.
If you lift the flap, then you try to do, and as Dr. Kumar is saying, that it becomes very difficult to remove the complete epithelium. So better to remove epithelium totally first, then lift the flap.
Yes, very relevant point.
Just one point I want to make is excellent video, Sujata, emphasizing all points. Just that, debriding epithelium is extremely important, because sometimes when the striae has been there for some time, the epithelium tethers the striae. But occasionally you come across these flat striae on the first post-operative day, on the second post-operative day, when we see the patient immediately. In these cases, we can get away without even removing the epithelium, just hydrating the flap and stretching it perpendicular to the direction of the striae.
The first case I showed.
Yes.
I completely agree.
Yeah, I agree. Any tips for flap suturing in these very thin flap? Namrata, you have anything to add for the?
I think I would rather glue them rather than suture them, because then you are not altering the contour of the flap at all, or the cornea. So it makes sense to glue them all around.
Can I just ask a question, ma'am?
Yes, Naga.
Yeah, lovely videos, Dr. Sujata ma'am. I just wanted to ask, what's the usual consensus? Like, because flap striae are known to be more common in thinner flaps. So suppose you have a 90 micron flap, and on table you see that the moment you remove the speculum, there is a slight flap misalignment, and you put it back. Definitely, if there is a problem, then you put in a BCL. But do you put a BCL in all the cases where you have a 90 micron flap?
No, I wouldn't.
No, right? Yeah. Just wanted to.
Satyajit, you want to
Most
ask?
often we are making 90 micron flaps using a femtosecond laser.
Yeah.
With the femtosecond laser, usually the incidence of flap striae, flap slippage is much less, because the way it settles down is much better than a microkeratosis created.
So I think best is to go flapless.
I was waiting to hear that. But also, if you put any adrenergic, the risk of getting flap striae and flap, slippage is much more. So one has to avoid, putting even those small little, anything which contains phenylephrine or, that has to be totally avoided. And that's one of the causes. And second thing, I think most critical to avoid flap striae is to dry adequately, give enough time. Most often we finish in 15 seconds and then we are off the speculum. If you have to wait, ideally maybe 2 minutes is the time. But I don't think any of us waits 2 minutes.
Yeah. Thank you very much for the inputs. We shall now go on to our next speaker, Dr. Susan Jacob, and who is the director of the Dr. Agarwal Refractive and Cornea Foundation, and with a huge experience. And she is going to tell us something very important, which is quite a rare entity now. How would I treat epithelial ingrowths? On to you, Susan.
Thanks so much, Chitra ma'am. I'll just start with my presentation immediately. This is on epithelial ingrowth, and of course, epithelial ingrowth is very easy to distinguish from other interface complications. We all know how it happens. It could happen due to primary implantation during surgery, but the more common, mechanism that it happens is that the edge of the flap is not stuck properly, or there's a small gap, and a fistula develops under the flap, which allows the epithelial cells to grow into the interface. Of course, the incidence is decreased with femtolasic and SMILE as compared to microkeratomes. The risk factors, as I just said, microkeratome flaps. Another risk factor is hyperopic LASIK, LASIK after radial keratotomy, and a common one is intraoperative epithelial defects. You also major causes flap lifts for enhancements or any other purpose. So that's another very important causative factor. You may have mild clinically insignificant epithelial ingrowths, which are defined as those that are within 1 to 2 millimeters of the flap edge, and if they're really not causing any problem, you can just observe them, and especially if there's no fistula associated with it, which you can make out just by doing a fluorescein dye staining. If you have complications, of course, you might want to treat. So it's been staged, as I just mentioned, within 2 millimeters, more than 2 millimeters, and those where you have other complications such as, when it extends into the visual acuity, visual axis, decreasing the acuity, it extends to the edge of the pupil. Again, that can cause glare. You can sometimes have topographic abnormalities due to the epithelial ingrowth, such as localized flap elevation, irregular astigmatism, and so on, and decrease in the uncorrected and best corrected visual acuity. And of course, in the last stages, you could also have induced keratolysis and focal flap lift. So again, a lot of techniques have been described for treating epithelial ingrowth. Generally, of course, like I said, you can observe for peripheral epithelial ingrowths, which are just static, which are not progressive, and which are not causing any visual symptoms. But if any of these things are happening, you would want to lift the flap and remove the epithelial cells from just not just from the bed, but also from the posterior surface of the flap. And then you can replace the flap. You can, of course, also apply adjuvants such as mitomycin C or alcohol, or sometimes combine it with a PTK. And the other additional measures, as also just described by Dr. Sujata, was flap suturing, fibrin glue, and so on and so forth. That's basically to kind of avoid a recurrent epithelial ingrowth. And you can also do a YAG laser treatment. So I'll just show a couple of videos. Here was a case who had a partial, really it was referred to us. She was a 21-year-old who underwent LASIK for minus 2.75 diopters OU. The interesting thing was she had a free cap in the right eye, which was replaced with the primary surgeon. Laser ablation was not done. So they didn't really perform the excimer laser. It was just a free cap replaced, and she was referred 1 month later for a displaced flap. And this is how I saw her. And so we took her up for surgery. This was a topographic map of the patient. Maybe I'll just, and this was the anti-segment OCT, which definitely showed an epithelial ingrowth under the surface of the displaced flap. So here you can see what I'm doing is just lifting up that flap and seeing what is there under it. A lot of epithelial ingrowth, obviously, because that was a very loosely adherent flap. So here the important thing is because we know that this flap itself is a very odd shaped flap. So this is one trick that I find very useful, using the endoilluminator to kind of find out the edges of the flap, because this is not a complete flap. This is just a partial flap which was created, and you want to kind of align it back to the right orientation once you're done. So you see the endoilluminator really helps you in identifying the edges of the stromal cut. And what I do is go ahead and make those aligning marks. And as it was just mentioned in the discussion prior, you can have very loose epithelial tags there. So that's the edge of the free cap, and then there's a little bit of epithelium that is kind of connecting everything in place. Obviously, not much use of retaining that epithelium in place. So what we do is scrape off all that epithelium and remove also all the epithelial ingrowth from the cap undersurface, as well as from the bed, and clean up the entire epithelium, not just under the flap, but also on the edges of the bed. So once that's done, what you do is you do this with a number 11 blade. So here you can see I'm doing it with a Mirocell sponge, but you also go ahead and do it with a number 11 blade. And I've gone ahead and marked the edges of the cap, and then you go ahead and replace that. So this is a complication where you've got a displaced flap along with epithelial ingrowth, and these have to be managed also. Again, now you can see what I'm doing is stretching it into place and using that endoilluminator light to make sure that the flap is completely aligned and put it back in place. of course, after doing the striae test, which kind of lets you know that the cap has stuck in place. I also put fibrin glue along the edges, which Dr. Mahipal just mentioned, just so to make sure that there's no recurrent epithelial ingrowth under the flap. That's the striae test, which Dr. Gaurav just mentioned. I waited for sufficient time. I think I waited for almost 7 to 8 minutes in this case to make sure that the thin cap was attached properly to decrease the risk of a recurrent epithelial ingrowth, and also applied fibrin glue all around, again to decrease the chances of a fistula forming and leading to a recurrent ingrowth. So we've got this picture 2 months later and quite an improved topography. And you can see again the on retroillumination, the margins of that displaced cap. 4 months later, this is how she looked, and we thought that it was time to go ahead and do a treatment for the eczema, for the myopic correction, which had never been done for her in the first place. Of course, we do a PRK, so using epithelium to remove using alcohol to remove the epithelium, peeling it off carefully, and not using a rubbing movement of the forceps, because you don't want to displace that flap which was adherent. And once you've done that, you can actually see the borders of that original displaced cap there. Go ahead and do the eczema. And this is the patient 3 weeks post-operatively, uncorrected visual acuity of 6.4, and did very well. I'll show you a couple of more videos. Here is a patient, this we'll probably just skip through because some of this is similar to what Dr. Sujata just showed, who presented with macro striae as well as with epithelial ingrowth. And here is again a place where you need to mark the upper surface of the cap as well using an irreversible letter. And also you can use the endoilluminator to make out which side is up. You can again see lots of epithelial nests underneath that cap with also a displaced flap. And I've also got alignment marks. You can see that displaced flap is completely gone and lying over the conjunctiva. This patient had undergone two washes or replacements of the cap, and then she was referred here for management. So what I'm doing now is lifting up that flap, and you can see this is basically a nasal flap which has been created. Remove all the epithelium again using a Levin blade as well. So this has to be done from both surfaces, the under surface as well as the over surface. And just as Dr. Mahipal just mentioned, I've also removed it from the top of the cap and using hypertonic solution to swell up that cap to get rid of the striae. And once that's done, we see that this cap really looks much better now. And we go ahead and put it back in place. Also use sutures to prevent, to get rid of all the striae, and at the same time use fibrin glue to get rid of the chance for any fistula remaining there and thereby leading to a recurrent epithelial ingrowth. So here we've kind of used all the techniques that can be used for this patient. And basically we got a very good result. This was a patient post-operatively. I think I also have a retroillumination picture. Yes, that's it, which shows that even these very bad striae and epithelial growths can really have a very good visual outcomes after the suture removal. So here's another epithelial ingrowth. This was in a smile patient, and this has happened at the edge of the incision. What I did here was use the circle procedure to kind of convert that smile interface into a cap, into a flap, the cap into a flap. So what I've done is that part of the flap is then raised up, and of course you scrape it off from both sides and then replace it, applied glue on the surface, and placed a bandage contact lens. Can really have lots of management for epithelial ingrowth. As you know, the basic principles always remain the same. You need to scrape off all the epithelium and then make sure that there are no fistulas that are left behind which could cause a recurrent epithelial ingrowth. So I think that would bring me to the end of my presentation. And there's of course the YAG laser also, which is very much spoken about for this condition. I don't have any personal experience with it. I'd like to know if any of the faculty does have any experience with the YAG.
Thank you very much, Dr. Susan. I have a wonderful talk. A question here is, would any of you prefer using isopropyl alcohol, or would you think of using MMC besides just doing the epithelial debridement and all the other things which she said? Clearly, she has not used. Yes,
I think I would prefer to use 0.02% mitomycin C for 20 seconds in all these cases. I hope, Susan, these are not yours. All the cases are referred. I hope there are too many epithelial ingrowths.
No, ma'am. Referred cases, of course.
Many of them are.
I would feel more comfortable using 0.02% mitomycin C, and that is what we.
Yeah. Even I have used mitomycin C at all times, but anybody has experience of wanting to use isopropyl alcohol instead,
I use 20% alcohol because I feel de-epithelializes the cells. And even if you leave behind something which you're not able to see, some epithelial nest, then it doesn't at least proliferate in more. So I've done a couple of cases with 20% alcohol.
Yeah.
Used for LASIK, no, the same thing.
Yeah. Yes, Dr. Mahipal.
You can use both.
Yeah.
So both can be used, and the other thing that is very important in this is that you can also stain. So those are the things to delineate the whole thing. But Susan, I think it's a valid suggestion that you should use mitomycin C. That's very, very important. And at time, sorry, yeah.
We use alcohol sometimes, but I've not used mitomycin C so far. So probably that is a good suggestion.
They tend to regrow.
Also, I do use it with a little bit of caution because too much of strong alcohol has been reported to cause complications. So I think what Dr. Sujata ma'am said about 20% alcohol.
It is 20% alcohol.
Fibroblasts and all are addressed with mitomycin. So
whenever you have to lift a flap to remove the epithelium, the chances of having a recurrence of the epithelial ingrowth goes up very high. So therefore, using mitomycin C, and if there is a lot of removal that you have to do, then glue and then bandage contact lenses.
We have personally used mitomycin C, but I tend to agree with Sujata in the sense that, as far as toxicity to the epithelium is concerned, maybe diluted isopropyl alcohol at 20% is a better choice, because mitomycin C is more for preventing fibroblast proliferation, and maybe this might be a better choice. But excellent videos, Susan. Just one point is that always look for the track also, especially sometimes if you do not have something growing from the edge of the flap, but you have a central island, then often there is a track which is leading on to the island, and removing that track is also extremely important to avoid recurrence.
Yeah, of course, we do that, sir, with fluorescein staining. When we do that, we can kind of see that track, and that is, of course, addressed. I think the sutures and the glue go a long way in addressing that track, because the glue actually seals it off while the epithelium is healing over it. So
yeah, but I think a little devitalized flap.
More than suturing, the best way to stop epithelial ingrowth is actually glue, fibrin glue around it, because it creates a proper seal all around, and it prevents the epithelium from regrowing again.
Has anybody tried using YAG? I think some very low energy YAG I've heard of being used.
It has been reported, but I haven't used it.
I have used in a few cases, and in I think we did it in about 3 cases. Two patients it worked well. It took time. In a couple of cases actually we did very low energy over 2 or 3 sittings. And sometimes it works well to kind of it helps in stopping further ingrowth as well, and in one case it actually resolved a little bit as well. But frankly, there's no technique that I can describe which will work well, because it's like hit and trial kind of a thing. Yet maybe somebody else who has more.
I have a question for you. All the epithelial ingrowths that you showed were in the interface with a normal flap or with flap striae. I think it gets very tricky when you have an epithelial ingrowth in a buttonhole flap, and that is sitting right in the center.
Yes.
Have you had the chance to address such cases, or how would you?
No, I really haven't come across. I mean, I haven't had to handle personally epithelial growth with a buttonhole. Yes, it does make things much more difficult, because you don't want to. Generally, buttonholes are central over the visual axis, which creates it much more headache, because you need to make sure that you don't damage the flap or the cap or anything of that sort. And also lifting up that again is a bit of a problem, because again you have a chance of an epithelial growth from that. I really don't have much experience, but I guess I would kind of use the similar principles and put in glue. You can't put sutures there obviously, because it's the center, but I would kind of make sure that I do the striae test, make sure that it's completely adhered, and then I would still take precaution and put glue and put a bandage contact lens.
Yeah, thank you. We have a number of speakers, so we'll go on to our next speaker. Dr. Praveen Krishna, are you there?
Yeah, he's there.
Yeah. Dr. Praveen Krishna is another cornea refractive surgeon who doesn't need no introduction, and he's one of the directors of the famous LV Prasad Eye Institute, where a lot of talent emanates from, and he heads the cornea and the refractive and the cataract and the contact lens services. And he's going to talk on a very interesting topic, interface challenges and solutions, and he's going to work magic talking all of it in 8 minutes. Or 10 minutes, I think.
Thanks a lot, Chitra, and amazing talk so far, and thanks for having me here. What I thought I will do today is actually speak on interface complication that is potentially not spoken about a lot, and briefly allude to the other interface complications that also tend to be confused with PISK or pressure-induced stromal keratitis. And because of the fact that this is an ARC session and there potentially are also going to be a lot of students, I thought I'll keep my talk a little basic and go back to the principles about why this occurs, and then talk about how to recognize this, and then talk about how to treat this and avoid it. So PISK or pressure-induced stromal keratitis is known by a lot of other names. It's also called interface fluid syndrome, PILK, and PLEK at different time points. But probably the most appropriate name is still interface fluid syndrome, because neither is it a keratitis nor is it a keratopathy, and it is not something that is induced by edema. So let's step back and see what causes this condition, or IFS, and interface fluid syndrome. The fact that it occurs only in surgeries where there is a lamellar interface, like in LASIK, means that it requires an anterior lamellar interface to be present, and it does not occur in surgeries where you have a posterior lamellar interface, say for example in TSEC or DMEC or even in DALC surgery. So there are two reasons why you have interface fluid: either elevated intraocular pressure or some amount of endothelial dysfunction. So elevated intraocular pressure can occur after LASIK surgery because of a number of reasons. Could be because of steroid-induced rise in IOP, probably pre-existing missed glaucoma, and sometimes even uveitis that can occur after LASIK surgery. Endothelial dysfunction, again, typically occurs in most cases because of missed endothelial dystrophy, does not occur immediately post-op, could be because of endothelial damage, this has been reported as well, and very rarely a split in the Descemet's membrane, a case of which I'll show you a little later. So again, thinking about what is the structure of the corneal stroma and how does this lead to the development of interface fluid syndrome, all of us know that the stroma comprises mainly of collagen fibrils, cellular elements like keratocytes, and then an extracellular matrix in the cornea. But what is interesting about the fact that the cornea is not uniform? The stromal lamellae are distributed differently based on the depth at which they are present. The stromal lamellae in the anterior part of the cornea, as you can see in this histopathology section, are much more compact, and they're also much more intertwined. And this is the reason why you do not tend to get a lot of corneal edema in the stromal lamellae in the anterior stroma, whereas in the posterior stroma, they tend to be more parallel, and that is why they tend to be separated more easily if you have edema that occurs in the posterior stroma. And as most of us have noticed, even after cataract surgery, when you get folds on the cornea, these folds and the swelling on the cornea occurs mostly on the posterior surface, whereas there is only minimal change on the anterior surface of the eye. So why does increased intraocular pressure or endothelial dysfunction lead to fluid accumulation within the cornea? All of us know that the endothelium actually is a monolayer that has tight junctions, typically does not allow fluid to seep in between these tight junctions. But there is a metabolic pump in the endothelium as well, which also tends to reduce the amount of water and keeps pumping out excessive water from the cornea. And the cornea is about 90% water anyway, in most of the times. So there needs to be a balance that is maintained between the hydration that is present in the cornea and the two surfaces in front, that is the tear film and the aqueous lake that is behind. So anytime there is a disturbance in this homeostasis, where you have either an increase in the intraocular pressure or a reduction in the pump function, which pumps out fluid from the stroma into the aqueous humor, you tend to have accumulation of fluid within the cornea. And typically in eyes where you do not have an interface, like in bullous keratopathy after cataract surgery or in Fuchs, most of this fluid either accumulates within the stroma or accumulates just under the epithelium, which actually is another potential interface. And this is again the similar mechanism where it tends to occur beneath the LASIK flap as well. So there have been studies done in eye-bank corneas after having a LASIK flap, looking at how much pressure will induce this kind of interface fluid. And they've also been staged into different stages. Like stage 1 is only a mild interface fluid syndrome. Stage 2 is moderate, where you start to see a symptomatic thickening of the stromal area with the interface haze and small fluid pockets as well. and then you have a symptomatic diffuse confluent pocket with surrounding haze as well. So how is this recognized typically, and how does this appear when you examine a patient who has this issue? So most of us imagine that when you see or you expect to see a patient with interface fluid syndrome, you think that this is going to show up as fluid or stromal pockets within the stroma. But this is not entirely true. This only occurs late in the stage of the disease, and there are a lot of other signs that we actually can look for early in the post-op period. For example, this patient is somebody who underwent LASIK surgery, and this patient is somebody who had a myopic refractive error. And because of this, this patient had interface fluid syndrome later on. So preoperatively, you'll see that this patient had a low refractive error of about -3.5, and then this patient had a normal corneal topography. At the 1 week post-op visit, the patient had a very good correction and 20/20 at 1 week. But then the patient was lost to follow-up, supposed to come back after 1 month, but comes back after 2 months and continued to use steroids. And this patient, again, you see, has an area of steepening on the central part of the cornea with a decrease in the vision and an increase in the refractive error of the eye. And when you examine a patient like this, though the intraocular pressure on eye care tonometry, it's important that Goldman ablation tonometry might actually mislead you and get erroneous IOP readings. You have to take IOP readings from the periphery of the cornea or with a machine that is non-applanation, which is like a Goldman ablation tonometry. So you don't see any changes in the cornea. But then when you look at the topography, you'll see that at the 1 week visit, the average K mean was 41 diopters. And at the end of 1 month or 2 months, it is increased by almost 1.2 diopters. And this typically occurs because of raised intraocular pressure. So look for changes in the topography of patients as a first sign of interface fluid syndrome before you actually start to see fluid in the interface. Another way in which these manifest is this patient who had, again, a low refractive error of -4, no cylinder, pre-op normal topography, underwent LASIK, and then at post-op day 7, you see the patient has a relatively good correction, 20/20 in the right eye, 20/30 in the left eye, which again was the best corrected vision. And then at 30 days post-op, 1 month post-op, you see there's a drop in visual acuity, and there's a change in refraction as well with a myopic shift. So myopic shift is the other way in which you can diagnose these patients who have interface fluid syndrome, and you see that the pressure was about 30 millimeters of mercury in both eyes. But when you see this patient again at the slit lamp, you see that there's almost no change in the contour, no change in the interface as well that you'll notice in the slit lamp. And in this particular patient, there was no evident anterior central steepening of the corneal topography as well. And this is where OCT helps a lot. In OCT, typically you'll see an interface after LASIK, but then this interface is usually not very distinct. But if you have fluid accumulation around the interface, you'll see a stippled kind of appearance on the OCT that tends to lead you to suspect that there might be fluid accumulation within the stroma as well as within the interface as well. So this patient was diagnosed as IFS, started on oral Diamox, pressure went down, and you see that the visual acuity improved by itself to 20/20 with minimal correction at 45 days post-op. Now, how do you differentiate this from other interface conditions like DLK or diffuse lamellar keratitis? Now, diffuse lamellar keratitis, again, is an inflammatory condition that tends to occur in the early post-op period after PISK or IFS. And several times, surgeons tend to mistake DLK with interface fluid syndrome because the appearance of both of them can be relatively similar. Now, this is a patient who has interface fluid syndrome, looks very much like DLK. So, and because intraocular pressure is erroneously measured to be low, the normal response is to lift the flap up and wash the interface or to increase the steroids. So when you increase the steroids, the problem gets compounded. So one of the best ways to differentiate the two is to remember that DLK tends to occur in the early post-operative period in the first week, whereas IFS tends to be late. It's about 3 weeks or later. There is a change in the refraction and keratometry in IFS, whereas there is no variation in DLK. And on topography, there is steepening of the cornea in case of IFS, whereas there is no steepening in DLK. This can also occur after other surgeries that have an interface like SMILE. This is a patient who had SMILE post-op day 7. And if you look at the OCT, you'll see clear separation and fluid pockets at the interface after smile surgery as well. And has been reported in literature in several cases too. So this patient, preoperative topography before smile -5 with a low cylindrical correction, did very well in the early post-op period. So at 1 week post-op, you'll see the patient is 20/20 uncorrected, but again did not stop steroids and had a steroid response. So at 1 month, the patient becomes myopic and then the vision drops again. And this patient has a diffuse haze in the interface, and we diagnose this patient as interface fluid syndrome. As you can see, same kind of stippling on the OCT, which again led us to start Diamox, and eventually the patient got better. But sometimes if this fluid is present in the stromal or in the interface for a long time, it can lead to interface scarring, and this can lead to a hyperopic shift in the refractive error long term after the fluid has resolved as well. There also are scenarios where you have endothelial dysfunction, like in this patient who had LASIK about 10 years ago and then came to us with severe interface fluid, though she was doing very well in the early post-op period. And you can see that there is a lot of fluid collection and a flap with epithelial ingrowth as well. And if you look at the OCT carefully, you'll see there is swelling of the stroma as well, which indicates that this patient has endothelial dysfunction. And on specular microscopy as well, we could see guttae in the periphery of the cornea in the other eye. After endothelial transplant, DMEC, this actually resolved by itself and did not require any intervention. And this is the OCT after doing an endothelial keratoplasty for this patient. Similarly, you can have a combined etiology where this patient who had an iris implant had intraocular pressure that was elevated as well as endothelial dysfunction, and this led to interface fluid. This patient required a TRAB and then required a DBEC as well, and after both were done, patient again recovered to almost completely normal vision with no interface fluid after doing the endothelial keratoplasty. Last kind of scenario where this can also occur is in a patient who had post-LASIK ectasia and then developed hydrops in that cornea and had a LASIK flap, and so had fluid collection under the LASIK flap, and this had to be sutured because unless sutures were made, were put in, the split in the descendants would not have closed, and there would have been interface fluid for a long time. And this patient within a week actually resolved very well and achieved very good visual acuity correction after the surgery. So to summarize, IFS or PILK or PISK or PLEK needs an anterior lamellar interface, cannot occur after PRK, and usually occurs because of elevated intraocular pressure or because of endothelial dysfunction. Most common scenario that we are faced with after LASIK surgery is elevated IOP. So remember that do not just take IOP with a Goldman appellation tonometry, also check IOP in the periphery of the cornea. Steroid-induced glaucoma is more common than we think. In fact, 1/3 of the population has been reported to be moderate responders by using steroids. And if you look at the risk factors, one of the risk factors is actually high myopia, which is where we do most of our LASIK surgery. Kind of steroids, dexamethasone, prednisolone are probably the most common causes, followed by fluoromethalone, and which is one of the reasons why we prefer to use loteprednol after surgery. But I think the best way in which you can prevent this is to use less steroids for a shorter duration and to be aware of what are the early signs of IFS after surgery. Thank you very much.
Thank you very much, Dr. Praveen. That was an amazing talk, and we just never cease to learn some more in some of your talks. So practical and relevant. I have a question, very simple. I mean, we've hardly had a pressure-induced stromal keratitis in spite of our large numbers, and it was a very transient event in one of my patients. But how long would we actually use anti-glaucoma medication in these eyes, especially when it is early on? Any of you have thought, like, when would you decide? 2 to 4 weeks is enough, you stop it? Because anyway, the IOP recordings are not very reliable, or when the slit lamp photo gives us or OCT tells us to stop?
So typically, because these patients require only short-term therapy, oral anti-glaucoma medications like Diamox tend to work quite well if they're tolerated well, and short duration, couple of weeks, like you said, and withdrawing the steroids usually takes care of the problem.
Okay. One thing which, because of the paucity of time, you couldn't cover, I would definitely take you on that some other time. even if you've had a DLK, has anybody had an experience where they needed to do a second interface wash for some of these patients? And if you were to do a second interface wash for a DLK which has not totally gone, then what would be the kind of time interval? Would you do it immediately the next day, or would you wait for a time frame? This is for some of those very rare events of a severe DLK happening. Ramurthy, Gaurav, Dr.
We have
Mahika.
had occasions to do a second wash. I mean, it's been extremely rare, more during our microkeratome days, though I don't know whether the microkeratome or the femtolasic has any role to play in this. But when it has been recalcitrant and persistent, we have had to do a few cases. It has been the first wash did cause a little bit of subsiding of the interface inflammation, and then in spite of the steroids, when it did not subside, we had to intervene once more, and finally the results were reasonably satisfactory. Just one point in addition to what the excellent presentation that Praveen made was, another entity which can sometimes be confusing is the central toxic keratopathy. It's most important to differentiate between these three, simply because in DLK, steroids is the mainstay of treatment, and for PALK, if you use steroids, you're going to worsen the condition. And with central toxic keratopathy, though the picture looks quite devastating, frankly, no treatment is needed. I mean, just with observation, though it takes some time to resolve, steroids may not worsen the condition, but even without that, the condition is likely to resolve over a period of months. Any comments on this?
I think we are running short of time. Sorry. Just one more question I have for the expert, and Shrital, you start sharing thing. Supposing you have a hyperopic shift after a CTK, as Dr. Ramurthy has discussed, has anybody done a treatment for that, or have they also regressed with time?
You should not. You should not.
They generally regress with time. I don't think you really need to do.
Yeah, absolutely. In fact, you should not touch it. I mean,
yeah. Okay. I think we are running late, though there were wonderful discussions, and I'm sure all of us have been learning all through. So we shall now go on to Dr. Sheetal Brar, who is again Senior Consultant Cataract and Refractive and Cornea from Netradhama Super Specialty Eye Hospital. And I've stopped counting the number of awards, and she walks up the stage. I actually sometimes forget to clap to, as if it's a constant feature of Sheetal getting awards. So she's going to take us on to a very interesting topic. How would I handle regressions? On to you, Sheetal. Your screen is not sharing.
Yeah, ma'am. Thank you so much, ma'am, for the kind invitation and introduction. Let me share.
I think it's a whiteboard again.
Whiteboard. You have to stop sharing and share again.
Share again. And what do I share now? Google Chrome. This I'm supposed to share. Can you see my slides now?
No.
Dr. Sheetal, can you open your presentation first and then start sharing? Stop sharing and then open your presentation.
Okay. It's actually already open. Okay. I'll try that.
Soundarya, be ready.
It's already open actually, but why I'm not able to share?
Would we do one thing, Sheetal?
Yeah.
Dr. Anand Sethi will guide you. You come next.
Okay, ma'am.
Dr. Anand, you have her number. Could you talk to her? Yes. And Soundarya, can you start?
Okay.
Dr. Soundarya, can you share your screen? And Dr. Soundarya is a young cataract, cornea and refractive surgeon from the Eye Foundation group of hospitals. And I'm sure her talk is going to reflect on the amount of knowledge which is hidden in this young brain. So her topic is, how do I plan my cross-linking protocols when combined with the refractive surgery? On to you, Soundarya.
Good evening to all the respected panelists. Thank you so much, Chitra ma'am, for the introduction and for this opportunity. So I'm going to be talking about combining laser vision correction with cross-linking. So as we all know, laser vision correction has shown excellent immediate post-operative results. However, when it comes to long-term visual outcomes, especially when we're correcting higher refractive errors, the results have been less satisfactory. The main reason being the need for retreatment and the cause being regression. So the need for retreatment in high myopia goes up as high as 30%, and the incidence of ectasia is about 0.03 to 0.6%. So as we do a tissue removal and a flap creation, it ends up causing a biomechanical instability. So combining cross-linking is theoretically thought to compensate for this biomechanical weakening caused by the LASIK. So this is based on the fact that cross-linking for keratoconus has shown to cause an improvement in vision as well as the corneal curvature, and also both these factors are found to remain stable even after 6 years in cases of keratoconus. So now the so-called extra procedures can be combined with either PRK, LASIK or SMILE. The primary goal of combining cross-linking would be to prevent post-LASIK ectasia, and the other goals would be to improve long-term refractive stability and also to reduce the rate of regression, especially in cases of hyperopes and high myopes. Currently, there are no consensus or recommendations as to what is the exact indication for adding a cross-linking. However, they have told that patients with certain risk factors for iatrogenic ectasia and regression could be good candidates. So one would be young age, high myopia or hyperopia, as I've already told, patients with thinner corneas, patients with borderline residual bed thickness, patients with moderately high ectasia risk score, and patients with borderline topography which is not amounting to the diagnosis of keratoconus, for example, an IS asymmetry or a borderline bad display value. And other contributing history is also important, like chronic allergy, eye rubbing, or family history of keratoconus. Just a few examples. So at our center, we tend to mostly combine extra procedures with PRK. So cases like this where there is a thinner cornea with as we can see, it's around 460, 470 thickness with a moderate amount of myopia, they would be good candidates. Or here with a normal refractive map, as we can see, but with borderline changes in the pad display again. Or in cases with borderline thickness around 480 with a higher amount of refractive error that we need to correct, again we could add cross-linking, provided that the residual stromal bed and the PTA are within normal limits. So this is a case of just an inferior steepening with everything else looking absolutely normal with a low refractive error to be corrected. So in these kind of cases, again, we do go ahead and add cross-linking, and in these kind of cases, we have done full fluence cross-linking, especially like a 30 milliwatt for a 3-minute protocol can be done. But what needs to be remembered is whenever we see just an isolated inferior steepening, it's always a good idea to go ahead and repeat the topography to see whether the steepening goes away. In most of the cases it does. And this is a patient where the topography looks fairly normal with a good thickness and a minimal amount of correction that has to be done. However, in the cornea, the TBI is found to be abnormal. So here again it is debatable whether in such cases the extra procedure is absolutely needed or not. Procedure-wise, here we're going to be doing a shorter riboflavin soak time with a lower total UVA energy used when compared to what we do for keratoconus. And in the LASIK extra, that is flap-based procedures, we're going to initially finish the laser procedure, then add riboflavin to the stromal bed, and then once the riboflavin is instilled, the bed is going to be irrigated and the flap is going to be repositioned, and then the UVA irradiation is going to be done. In PRK extra cases,
just 1 minute, Soundarya. Please all mute yourself because there's a continuous talk from the background. Okay, Soundarya, carry on.
So in the PRK extra procedures, the only additional step that we're going to be doing is adding a mitomycin C, a 0.02% mitomycin C, in order to reduce the amount of haze. And in SMILE extra procedures, the riboflavin is usually instilled into the cap interface, and then it is washed, and then the UVA radiation is applied. Now there are multiple protocols that have been suggested, but there is no standard as of today. So these are the reference articles for the protocols. So the riboflavin used here is going to be of a higher concentration, where we use a 0.1 in a normal keratoconic eye. Here we're going to be using a 0.22 to 0.25% riboflavin. And in the various studies, they've used it anywhere between 45 to 90 seconds, and even up to 120 seconds in certain studies. And the UVA radiation is usually used at 30 milliwatts for again 45 to 90 seconds with a total energy of 1.4 or a 2.7 joules. So at our center, we use 90-second soaking with a 30 milliwatt for 90 seconds at the half fluence rate. So Ohana et al. Reported a study with PRK extra where they used full fluence accelerated protocol with a 9 milliwatts for 10 minutes. But in that study, they reported more haze. So the riboflavin, because it is used in the stromal bed, it obviates the need for de-epithelialization, which is one of the major drawbacks of cross-linking. And since the flap does not contribute to the biomechanical stability, the cross-linking of the flap is not necessary, and it could also be detrimental because it can lead to subsequent shrinkage. And it is also important to avoid riboflavin contact with the flap, and some authors have told that the flap can be folded onto itself in order to prevent the spilled over riboflavin from touching the inner surface of the flap. When talking about the refractive outcomes, there have been various studies which have compared LASIK extra with normal LASIK in high myopes, and they've shown that the predictability and visual acuity are better. So one study by Tanitol showed at 3 months, and the Canalopolis studies followed up the patients up till 1 year and 2 years, and they showed that the uncorrected visual acuity was found to be better in the extra group. And when you're talking about stability, majority of the studies have shown greater stability of refraction in the LASIK extra groups, and they have shown comparative or better results in refractive and keratometric stability in extra groups. And observational study up till 2 years of the Canalopolis et al. Study also showed the similar result. And they have also told that addition of CXL is going to have an influence on the epithelial remodeling as well. So in higher myopia, the study by Canalopolis et al. Showed that there's a significantly lower increase in the mid-peripheral thickness, so which is the major reason for the regression in such case. In hyperopic correction, again, the contralateral eye study which was conducted showed the lower mean regression in cases of combining with extra procedures. There was a study with a longer follow-up, a 4.5-year follow-up. However, the sample size was too small. When talking about safety, all the studies have shown that the endothelial cell count is stable and there's no visually significant haze. However, Saylor et al. Reported higher incidence of DLK and a delayed visual recovery in the LASIK extra group. And also in PRK extra, there may be a slight increase in incidence of haze, but not visually significant, which usually resolves in 6 months. And this can be reduced by addition of mitomycin C. So it is, as we know, it is a challenge to demonstrate a statistically significant reduction in ectasia risk because of how rare the complication is and how the large amount of sample size that is going to be required. So there was one report in 2017, the first case of post-LASIK ectasia in a patient who underwent LASIK extra. But what needs to be remembered here is this patient had undergone a microkeratome LASIK in an FFKCI, which is ideally not to be done. Drawbacks of combining cross-linking: one is the increased procedure time, but not by much, and the increased risk of infection because of the use of riboflavin, a possible increase in corneal haze. And as we all know, cross-linking after creating a flap, so does it actually add to the biomechanical strength, is again questionable. And some authors have told that the flap may be more difficult to relift once an extra procedure has been done in case of necessitating an enhancement. And so the question of whether a specific normogram is required for refractive correction has come across, but most of the authors have agreed that it is not required because when they're going to be using the accelerated protocols, the necessity for the change in the refractive outcome is not going to be much. So the most important and most practical challenge in adding the extra procedures is going to be the cost burden that's going to be there for the patient. So to conclude, as we all know, post-LASIK ectasia is a very big challenge to treat. So if a prophylactic cross-linking can prevent this high risk in high-risk eyes, then extra may be worthwhile. So at present, we don't have adequate data. And as of today, what we know from the literature review is that adding a cross-linking is a safe option. But is it effective? So we are left with more unanswered questions like, is it effective in preventing regression and ectasia? What are the exact indications to add this procedure? And we definitely require more standardized irradiation protocols when adding the extra procedures. Thank you.
Thank you very much, Soundarya. You threw a lot of light, but I guess in the expert panel, there are fewer of us who are doing CXL extra, although I am convinced. So I think I'll take a question with Shreyas, and if Namrata or Mahipal, anybody wants to add, you could. So we do believe, we are convinced that it has a role to play in some of these very borderline suspicious topographies, and the aggression with which we have moved on to phakic IOLs, the requirement of an extra procedure has become far, far less. But having said that, believing there is some kind of a stromal remodeling which is more controlled because of the CXL add-on, would you try to, like doing a little higher refractive error in a thinner cornea where you expect regression, would you feel more justified in doing a PRK extra on this eye? Stress, I'm going to ask you that.
I think, I mean, Soundarya has beautifully summarized the entire talk. I would say at this time point, if there is a concern regarding regression, definitely we would go in only for a phakic IOL. Only if the rare case that the anterior chamber depth does not allow a phakic IOL are we going to consider PRK extra. Like Soundarya said, there is enough literature now to say that the extra procedure by itself definitely does not do any harm. How much benefit it gives is still very questionable. The very flash cross-linking that we have is whether it is sufficient to prevent ectasia altogether is less likely, and that's why we still have to follow the same stringent protocols that we follow for a regular PRK, even for PRK extra as well. So it's just including those slightly borderline corneas with slightly lower pachymetry, which normally we even hesitate to do PRK, but for a low myopia, these are the few cases where possibly an extra procedure is being done.
Sheetal, I have a small request. Dr. Shreyash is caught in a tight moment, so he needs to present his, give his presentation now, and I would be very obliged. I've tried calling you on phone to request. So you would come following Shreyash. And Shreyash Ramurthy is again a consultant cornea, cataract and refractive surgery and a very dynamic, amazing surgeon. And he is going to tell us what goes into planning for intact segments. On to you, Shreyash.
Thank you so much for having me over, and thank you, Sheetal, for allowing me to go ahead. So today I'm going to be quickly talking about choosing the ideal intracorneal ring segment. I think a lot of us have been using the intracorneal ring segment for a number of years now. But with the advent of various protocols, topo-guided treatments, where does Intacs fit into today's treatment is also something I'd like to cover. Before that, I'll go on and talk about how Intacs works and the planning which goes into choosing the ring. So essentially what Intacs does is by creating a kind of a localized steepening at the area where the Intacs is implanted. And this mid-peripheral steepening leads to a relative central flattening. And this central flattening is what gives us the flattening of the cone and gives you the overall visual benefit. So this originally was indicated for myopia, but we've obviously stopped using it for myopia and mainly using it for keratoconus and post-LASIK ectasia. I won't really say PMCD is an indication, not the true PMCD, but the pellucid-like keratoconus or the inferior keratoconus is where it is being used, not the classical PMCD as such. Of course, it needs a central clear cornea. Any central scarring is not in those patients. They would either go in for a contact lens or a DALK procedure. Contact lens intolerance, primarily because the aim of Intacs is to post Intacs contact lens fitting will be very difficult or can be more challenging, and therefore you want to avoid contact lens and choose cases in such a way that post Intacs you give them a reasonably good best spectacle corrected visual acuity. Choosing again eyes keratometry between 46 to 60. Anything beyond 60, the amount of flattening which the intracorneal ring segment is going to provide may not be sufficient to significantly improve the quality of vision. Thickness, generally we try to have 450 micron, and this is zone of implantation. So at around the 6 mm zone, the center may be much thinner than that, but that doesn't matter. It's mainly at the zone of implantation where it's important. BCVA 612 or less, primarily because in patients with very good BCVA, although with the current nomograms, we don't really see loss in lines of BCVA, but the older nomograms showed that patients with good BCVA, that is 6.6, 6.6 part, 6.9, had about a 25 to 30% chance of losing one line of vision acuity. Whereas patients with poorer visual acuity definitely benefited more with intracorneal ring segments. However, having said that, the chances of losing BCVA with current nomograms is quite unlikely. I will be primarily talking about Intacs, although Kera ring, Ferreira Mayo ring, and a host of other rings out of Brazil and Argentina are available. But I'll primarily talk about the Intacs planning. So preoperative spherical equivalent, location of the cone, and the amount of asymmetric astigmatism is what is going to decide the number of rings that we use, the thickness of the rings, and the arc length of the rings as well. So essentially, when we say preoperative spherical equivalent, this is going to decide the thickness of the ring. And we either have an Intacs which is implanted in the 7 mm zone, or more often we use the Intacs SK or Intacs severe keratoconus which is implanted in the 6 mm zone. So closer to the central of the cornea, greater the effect. So as you can see here, slightly less, the thinner segment gives a greater refractive effect when it is implanted towards the center of the cornea. Next comes the location of the cone. We look at the posterior float and see if the cone 50% of it is within the 3 mm zone, then we call it a centered cone. If it is 50%, more than 50% is outside the central 3 mm zone, then we call it a decentered or an eccentric cone. The reason is this is what is going to decide the type of segment that we are going to use. So if it is a symmetric cone, as in this condition, then we will use symmetric segments, centered cone, symmetric segments. And if it's a decentered cone, then we use asymmetric segments, that is a thinner segment superiorly and a thicker segment inferior. We also look at planning the incision. Now, when we are looking at the incision, what we are going to do is look at 4 parameters. One, we look at after transposition, on the topography, the steep axis, on subjective axis, the steep axis. Then 2 other parameters. On the posterior float, from the central point to the maximal point, we draw a line and extend it on both directions. This gives you the flat axis. The line perpendicular to that gives you the steep axis. Similarly, on pachymetry, from the thinnest point to the central point, take those 2 points and draw a line on either side, and perpendicular to that is likely to give you the steep axis. Now, this is a case where it's specifically chosen where everything correlates beautifully, but it may not be so in every particular case. But you want to try and either repeat your refraction or repeat your scans to ensure you're more or less having the correct location of the incision. Again, this is only primarily to decide the location of your ring also, because we are going to implant it about 30 degrees beyond the steepest incision is where the ring is going to start, and that is where it becomes more important. The incision itself does not have a great impact on the overall visual outcome. The other thing is once you've located this, so this is a central cone, like I mentioned, we are going to have and look at the spherical equivalent, and looking at the spherical equivalent of this particular patient, we are going to choose the kind of thickness of the ring segment that we are going to choose. So for an 8 diopter, as you saw in that example, we are going to use 0.45 symmetric segments. But looking at the other example, let's say a decentered cone, like in this particular patient, in decentered cones or where we use asymmetric segments, it's the cylindrical power that we are going to look into while choosing the ring from the nomogram. So in this particular, even after transposing, the cylinder magnitude is not going to change. So 3.5 diopter, as you can see in this particular individual case. And once we again look at the nomogram, and as you can see here, for that we'll be using a 0.21 superiorly and a 0.35 inferiorly. So it's the cylinder power which is going to decide the extent of thickness of the ring that we are going to choose. And usually, because it's decentered inferiorly, we have the thicker segment inferiorly and thinner superiorly. So this is basically about symmetric and asymmetric segments. Now, we also have an option of using a single ring. So basically what happens is when we are using 2 rings, we are trying to flatten the cone to the extent possible and giving an overall reduction in the spherical equivalent, flattening the cone and improving the visual acuity. Whereas with a single ring, there is a greater reduction in the astigmatism or the ISC symmetry. So whenever you have a higher ISC symmetry of greater than 10 diopters or so, then in those cases you do well to do just a single inferior ring, which helps in trying to shift the cone a little superiorly by causing a relative flattening inferiorly. So thereby the overall best spectacle corrected visual acuity also improves. So this is just one such example where you can see there's almost 10 diopters of ISC symmetry and those patients do well. Then you have the smaller arc segments. So normally the regular segments which I was talking about are the 150 degree segments. Now you have 90 and 130 also available. So it was found that to have a localized effect, progressively increasing from 30, 60 up to 90, you have maximal effect along that axis. Beyond 90, it has an effect on the opposite axis also, and therefore causes a greater reduction in the spherical equivalent. Whereas up to 90, there is a greater reduction in the amount of cylinder or the power along that particular axis. So in patients where the myopia is already less, or in rare cases who have a slight amount of hyperopia along with astigmatism, so in those cases, you don't want a global flattening and cause a greater amount of hyperopic shift. And in those cases, you can use a smaller arc segment, like in this particular example, with the patient as accepting a low grade hyperopia, but predominantly a cylindrical power. and where these arc segments work well. So where does Intacs come in today's options? Generally, in a centered cone, if there is sufficient thickness, we go ahead with a topo-guided PRK and improve the quality of vision. And if there is a significant residual error, we could either give glasses, contact lenses, or a phakic IOL. But if it's an eccentric cone, the topo-guided PRK procedures work a little less, are not as effective. So in those cases is where Intacs becomes very useful, as well as in post-LASIK ectasia, where very often it is an eccentric cone. And in those cases, you could implant a intracorneal ring segments. Like I already mentioned, contact lens fitting following intracorneal ring segment can be more challenging because you have a flatter center and a steeper mid-periphery. But of course, there are lenses, Rosque IC and miniscleral lenses which are available, which can be done post-Intacs. But in today's practice, I consider it a failure of case selection and using the Intacs if you're anyway going to put the patient on contact lenses, because most of these patients could have been fitted with the contact lenses even before the intracorneal ring segments. Topo-guided PRK or PRK can be done following Intacs also if sufficient thickness is there. However, there is an increased propensity for haze and epithelial hyperplasia along the channels, and this is something that you need to be watchful for. After intracorneal ring segments, if the best spectacle corrected visual acuity has improved significantly and the patient is comfortable with the spectacle corrected visual acuity, I'm sorry, the video doesn't seem to be running. But after that also, a toric phakic IOL can be used to debulk the amount of anisometropia that the patient might be having, and thereby improve both their uncorrected as well as best corrected visual acuity. So intracorneal ring segments is the only device which can mechanically shift the cone at this point of time, and careful case selection and good preoperative planning can give optimal results. Thank you so much.
Thank you very much, Shreyas. Sheetal, share your screen. Shreyas, I'm going to take a question with you. How have we modified our Intacs case selection with time, with experience? What do we do now?
So I think, in many practices, I think the number of intracorneal ring segments which was being done, let's say 6 or 7 years ago to now, has probably come down a little bit because our case selection has improved, and we know where topography guided PRK works. We were probably not doing as many topography guided PRKs a decade ago as we are now, and the case selection, understanding, follow-up outcomes of that has improved. So early moderate keratoconus, that is becoming the treatment of choice because the outcomes are far more predictable with a topography guided treatment than you have with an intracorneal ring segment. Having said that, it is still a useful device in that segment of patients where, like I mentioned, with the preoperative characteristics, there you can definitely use an intracorneal ring segment, improve the quality of vision, and then go ahead and do other refractive procedures to further improve that vision.
Thank you, Shreyas, for a wonderful talk and discussion. We shall now go on to our next speaker, Sheetal, who I've already introduced, and on to you, Sheetal.
Thank you so much, ma'am. I think the slides are now visible.
Yeah.
Okay, thank you so much, and good evening, everyone. Today I'll be talking about how to handle regression after corneal refractive surgery. So, by definition, what is refractive regression? So it's a gradual, partial or complete loss of the attempted correction and is defined as residual myopia or hyperopia of 0.2 diopters or greater shift occurring between two follow-up visits 8 weeks apart. It's very important to understand that the mechanisms of refractive regression, they arise from the changes at the level of the cornea. So these are the changes that occur in the cornea during the healing phase after a corneal refractive surgery, LASIK, PRK or SMILE, as opposed to any kind of refractive change occurring in the lens or in the axial length of the eye. So we all know there are some risk factors and causes which we are aware of: high preoperative refractive errors, young age, hyperopic refractive error, postoperative epithelial hyperplasia and stromal remodeling, abrupt discontinuation of steroids, especially after PRK, and postoperative dry eye is also linked with regression after corneal refractive surgeries. It's very important to differentiate a true regression from other causes of postoperative residual refractive error, such as improper data entry, decentered ablation, fluence issues, over or underdone nomogram, and intraoperative dehydration of the cornea. So while evaluating these cases, it's again important to understand the normal healing processes that occur after laser surgery, such as you might see a little bit of overcorrection in refractive error in the first few weeks after the surgery, and that's basically due to the calculated nomograms, the laser nomograms that we use that aim at slight overcorrection and they anticipate a natural regression of the effect. There could also be a little bit of induced astigmatism due to stromal and epithelial remodeling due to tear film disruption. So we must be aware of all these things. So a very important question is when to treat for regression. So I would say a very minimum amount of refractive error such as 0.5, 0.75 sometime may not need a treatment if the patient is comfortable and is not complaining. However, if the residual refractive error is significant enough or the post-operative aberration profile is affecting the quality of vision and the daily activities of the patient, I think you must decide about treating it. And the decision making differs from surgeon to surgeon and with the availability or experience that they have with a particular enhancement method. So the general guiding principles are you must wait for at least a period of 3 months and allow the refraction to stabilize. Ideal, I would say, is about 6 months, but sometimes the patients are very unhappy and they keep coming to you. So at least you should wait for 3 to 4 months if you want to plan enhancement. Correct elucidation of cause of error. So as I said earlier, differentiated from the other causes of residual refractive error. Proper counseling, and there should not be any contraindication for the chosen method of enhancement. So to evaluate, we must evaluate the vision of the patient, uncorrected and best corrected, manifest refraction, cycloplegic refraction is required to rule out accommodative spasm, and topography is really important to rule out post-operative LASIK ectasia as it could mimic early regression in early stages of ectasia, and also AIOS OCT to measure the flap thickness or the cap thickness and the residual bed thickness as well, which is very important to plan the enhancement. So early regression versus early ectasia. Here we have two maps. The first one is of a patient who had -9 power and he had LASIK, and after 6 months accepted a power of -1 with 0.75. And on the other hand, there is a moderate myopic patient who after 3 years of LASIK accepts the similar amount of power. So if we see the maps, the epithelial maps, the first map shows significant amount of thickening of the epithelium in the center, which is very classical of the early regression. And on the other side, we have thinning of the epithelium in the center, and this is surrounded by a donut-shaped thick epithelium, which is the pathognomic of early ectasia. So this is how topography and especially epithelial maps can help. So a medical management of regression has been described. And they say there is a forward shift theory wherein they say that the cornea becomes thin. Because the cornea becomes thin after refractive surgery, it becomes weak, and combined with high IOP, it can result in elevation of the anterior as well as the posterior surfaces, and this can contribute to myopic regression. And hence, if you lower the IOP, this may reduce the shift. So this is the basically funda behind it. So people have tried nipradilol 2.5% twice daily and timolol also, and they have seen good results. However, we don't really have personal experience with this type of management. So talking about different procedures, PRK versus LASIK versus SMILE, I think treating regression after PRK is probably most difficult because we have less options available. Repeat PRK is a possibility. However, we must be very cautious because there may be much higher risk of having corneal haze post-operatively. So might want to use mitomycin intraoperatively for a longer period of time, maybe about 1 minute, and also put the patient on a longer course of steroids. There is also option of thin flap LASIK or LASIK extra enhancement that has been described. To manage regression post-LASIK, there are various options: flap relift, flap recutting and making a new flap, side cut only, and surface treatment. So depending upon residual bed thickness and the quality of flap edge, you can have different options. So if the RST is good and the quality of flap edge is also good, so which means that the flap edge should not be should not have already epithelial ingrowth, or there should not be any melting or irregularity, then you can easily go ahead and relift the flap. but it has to be done in the most atraumatic manner so that you don't disturb the epithelium too much, because epithelial ingrowth incidence increases by 20 to 31% post relift. On the other hand, if the residual bed thickness is adequate but the quality of the flap edge is poor, then you have two options. The first option is flap recut at a deeper depth. So you want to make a deeper flap which is at least 15 to 20 microns deeper and also wider, and then you lift the previous flap along with the new flap. So this is a possibility if RST is good, or you can also make only a side cut which is in the original flap but a little smaller, about 1 millimeter smaller than the previous flap. So this is a video showing only side cut management for enhancement. So this flap is actually smaller compared to the original flap. So this can be used if the quality of the previous flap edge is not good. In a scenario where the RST is inadequate but the quality of flap edge is good, you can have two options again. If the thick flap is, if the flap is thick, 140 microns or more, then you can go ahead and do a flap recut. That is, you can make a thinner flap, or you can do also smile with a thin cap. Or you also have the option of doing a thin flap or a surface ablation in this scenario. If you have RST which is inadequate and also the quality of the flap edge is poor, then you don't have any option but to go ahead only with the surface ablation. So what are the options for enhancement in smile? We have surface ablation, thin flap LASIK, circle software, and subcap lenticule extraction, which is called re-smile or smile on smile. So PRK after smile is probably the simplest procedure that can be done. It is ideal for low enhancements. The mitomycin C might have to be used for longer time, again to prevent haze. It maintains the advantage of a flapless procedure. Thin flap LASIK has been described by Professor Dan Weinstein, and this is ideal for those cases of smile where the cap thickness was thicker, 135 microns or more, and you have to make a very thin flap of 80 to 90 microns, and you have to be careful that the hinge has to be away from the previous smile axis incision. Circle software is a dedicated software for enhancement after smile, and this allows the surgeon to convert smile cap into a flap, and it provides three types of cuts: lamellar ring, this is the lamellar ring, a side cut with a hinge, and a junctional cut which joins the previous interface. So depending upon the relationship of these three cuts, there are different patterns of circle treatment available, pattern A, B, C, and D. D is probably the most commonly used and also has been shown with shown to have easy flap lifts, and there are not many difficulties faced with this type of pattern. So this is a circle software being used for enhancement, the lamellar ring creation as well as the side cut. So smile on smile has also been described, and this is a possibility when you already know the previous smile parameters. So you need to know the previous cap thickness and the optical zone, because you will be planning the treatment at the same cap thickness, but you will be reducing the optical zone so that the side cut is so that it joins the previous interface. And this again is advantageous for maintaining a flapless procedure. This is a short video showing smile on smile procedure for enhancement. So you need to plan the lenticule cut and the side cut only. And when it comes to the cap cut is about to start, you need to lift the foot pedal and break the suction manually. And then you can go ahead and separate both the interfaces and remove the lenticule through the old or the previous smile incision. So you've done one case, two cases of smile on smile, and this method can be used for residual refractive errors which are higher, but this is suitable only if you have access to the pre-smile parameters, the previous parameters. Thank you so much for your kind attention.
Thank you very much, Sheetal. That was an amazing talk, and I had a lot of questions, but I think I have to do justice to some very good speakers who are yet to talk. I think, yes, I don't know whether you already added, but we definitely need to do a biometry in most of these cases where to rule out that whether we are dealing with regression or an increase in axial length. Do stay on with us. We shall now go on to our next speaker, Dr. Sri Ganesh, who is the Chairman and Managing Director of Netradhama Group of Eye Hospital, and of course, a very amazing cataract refractive surgeon with a huge number of awards and accolades to his attribute. And he's going to tell us how would I handle a lenticule remnant in smile intra and post-operatively. On to you, Sri Ganesh. Sri Ganesh, you have to unmute yourself, maybe. Cannot hear you.
No, Sri Ganesh is not.
Can you hear me now?
Yeah, yes.
Yeah, okay, good. Can you see me?
Yes.
Yeah. Okay, good. So let's start. At the outset, I would like to thank Chitra for inviting me to this excellent webinar on refractive surgery. And we have been doing SMILE for over 10 years now, and we have had some very interesting cases. I'll be talking to you about retained lenticule post-SMILE. So I am a consultant to Carl Zeiss Meditech. So for the first situation is where you have a retained lenticule introp. It is because of a lenticule tear. So this we will call as lenticule tear introp and a retained fragment. And this usually occurs when you have very thin lenticule, if you have low myopia, or you have OBL in the periphery, or if you have black spots typically in the periphery. And you can have some part of the lenticule which is retained back, and there is a risk of irregular astigmatism and loss of best corrected visual acuity if it's a fairly large chunk of the lenticule which you have left behind. So it is very important to identify for all beginners. We always ask them once they've removed the lenticule to put it on the surface of the cornea and check for the integrity of the lenticule, whether it is complete or incomplete. Examine the edges. You can also stain the lenticule with trypan blue and put it on a white sheet, and then it's clearer whether you have remove the complete lenticule. So when you're starting off, this is what you have to do. Suppose the lenticule is incomplete, it is not circular, you see that an edge is missing, then you will have to identify the remnant in the pocket. This you can do by the use of a slit lamp in the Visimax. The Visimax itself has a slit lamp. So if you use the slit lamp, you can see where the peripheral lenticule is there, because typically when you use the slit lamp, you see a very pristine edge if you remove the lenticule completely. But sometimes if the edge is not very clearly visible, that is where you have the retained peripheral bit of the lenticule because of the lenticule tear. You can also stain with tricot or red acetate drops. You insert it into the interface, and then it will stain the edge of the retained lenticule, the tear which is there, and that's how you can identify it. The other option is to dilate the pupil and use a coaxial illumination, stereo coaxial illumination. So on retroillumination, you can see the edge of the lenticule. It appears a little darker. You can also use an endoilluminator from the side, put off the microscope light, use an endoilluminator from the side, and then you can identify the edge. Another technique is to insert an air bubble in the pocket. The air bubble itself will go and settle at the edge of the tear, and then you can identify where the tear is and where the retained lenticule is. So these are some of the techniques for identification. Let me just show you a video of a lenticule tear. You can see there is a lot of OBL in the periphery, and this was a lower myopia. This is an older video. So here the Chancy dissector is being used. The superficial plane is dissected, and then the deeper plane. And then the lenticule is extracted with the microforceps. Once the lenticule is extracted, then it is placed on the cornea, and on examination you can see that one part of the edge of the lenticule is missing. You can see that is where the arrow is, the white arrow. That is where. Now this is a small area, so even if you leave it, there may not be much of a problem, but it is ideal to explore and remove. So here we are using the slit lamp, and also you can see the air bubble there. So you go in and you can see that is the area where the edge, the lenticule side cut is not very clear, you can go and then dissect it, remove it with the microforceps, and you can see that is the area. You can even match it to the lenticule like a jigsaw puzzle and see that it matches correctly, and then you know you have removed the lenticule. So that is the intraop management of a lenticule tear or a retained lenticule. Now let us, coming to prevention and management. So it's very important. Prevention is better than cure. So you will have to see that you completely separate the lenticule from both surfaces and the side cut along the entire circumference before you try to extract the lenticule with your microforceps. And in low myopia, again, the risk of this happening is more. So you can increase the peripheral thickness of the lenticule to 25 to 30 microns. And if you have a thicker peripheral part of the lenticule, then the incidence of these lenticule tears is less. Also, if you have OBL in the periphery, you have to be very careful when you are dissecting and see that you completely dissect the lenticule. Like I showed in the last case, because of the OBL and the low myopia, there was a tear. Coming to the retained lenticule post-op. So the patient may present post-op with loss of best-corrected vision and blurring of vision. There are two options. One is to explore through the previous smile incision, you explore the pocket and you can attempt to remove this. And the second option is to create a flap using the circle software, lift the flap, and then you do an open exploration and then remove the remnant which is there. So first we will look at exploring through the same pocket. You can open up the previous smile incision very easily, and typically you wait until the cornea clears. Suppose you have not been able to remove the lenticule completely, then and you have spent quite some time dissecting, then what happens is there is some amount of corneal edema and the visibility reduces. So typically the cornea takes about a week or 10 days for it to completely clear, and that's when you can do a proper assessment and go in and explore. You should always ask for the surgery. If you have done the case, then you review the surgical video. The case has been referred to you, always ask for a surgical video and see that there is a completeness of all the stages of the lenticule creation by the laser. That is the refractive cut, the side cut, the cap cut, and the incision. So if there is some incomplete treatment of the laser, or if there are black spots, then it may be more difficult. You may not be able to do a closed exploration. So always look at whether the laser was complete and whether the laser treatment has been done properly. And if that is there, then you can go ahead with the exploration in the pocket. ASOCT has to be done. You do a topography. Topography may show irregularity. ASOCT will definitely give you clues about the location of the retained lenticule remnant. Sometimes you may not be able to even make out of the ASOCT, so it is a good idea to always dilate the pupil and do a thorough examination with a slit lamp, a retroillumination examination, and then on retroillumination sometimes you can see the edge of the lenticule. So I'll show you some cases. So this was
running late already.
Okay, just the cases. Give me another 3 minutes. This is post-smile right eye uncorrected vision. He had 20/40, was referred. Best corrected vision was -1 +2, improving only to 20/40, and procedure was abandoned because they were not able to remove the lenticule. And this, you can see that the topography is very irregular. And if you look at the OCT, you can see that there is a retained lenticule there. This is exploration. You go in through the same pocket, and then you can see, you can look at the lenticule remnant there, and then you can dissect both the deep and the superficial surface. And then this was a patient where the surgeon said that he was not able to remove the lenticule at all. It had crumpled and then gone deep in the pocket. So you can see that the entire lenticule is there. And this is the pre-op and post-op topography. You can see that topography normalized very well, and this patient had 6/6 uncorrected vision. This is a final uncorrected vision. Best corrected improving to 6/5. This is the pre-op OCT and the post-op OCT showing removal of the lenticule. Open exploration can be done with the circle software like Dr. Sheetal showed. Indications are irregular topography, ASOCT is inconclusive, and it may show if ASOC shows multiple planes of entry. This is a case, I'll just show you. This is a 33-year-old female, spinal procedure, left eye was complicated. Best corrected vision, there was a loss of best corrected vision, improving only to 20/40. And this is the primary video. You can see there's a lot of black spots here. And there's a large patch here, okay? And this is when, suppose you have a large patch and if it's in the center, then it's best not to proceed with the dissection of the lenticule. Here, we are proceeding with the dissection of the lenticule because the black spot was in the periphery. You can see that there's more resistance when you're dissecting the deeper plane. The lenticule is removed. It is found to be intact. There is no remnant as such which you can notice. In all difficult dissections, you have to examine the lenticule. But you can see the topography shows central steepening and there is irregularity. ASOCT was not remarkable. You can see it's fairly okay, but epithelial maps were irregular. And on retroillumination, you can see that there was some shadow here, which showed that, okay, there may be some remnant. So here we are doing the exploration through a circle software and we just lift the flap. And here you can see that there is a sliver of tissue. It's a very thin sliver, maybe about 10 or 15 microns. So you can dissect that sliver off. That was what was giving rise to the central steepening on topography. And you can't see it on OCT also because it's very thin. It's just a thin sliver. So we removed it and just did a 20 micron PTK just to smoothen the surface. You can see that's the remnant, very thin. That's the PTK being done, and we put back the flap. I'll just show you the post-op. You can see this is the post-op. She improved to 6/6 parts, and this is the pre-op and post-op topography. You can see the topography has normalized. This is a clinical photograph post-op. You can see that there are no shadows. The retroillumination is very clear. We have published quite a few cases of the retained lenticule and management in the JRS. So if you are interested, you can read this article. Thank you very much for your attention.
Thanks a lot, Sri Ganesh. There's a whole lot of learning from your talk, but it's running so late that I'm not able to use your experience longer. And I'll sure come back with another different webinar later to learn some more. Thanks a lot.
I just want to ask you one thing. Intraop, you can also use an intraop microscope too.
Yes. You can use it, but you have to shift the patient to the
another
OCT. But it is better, of course. Intraop, sometimes it's inconclusive, the intraop OCT. So staining probably is a better idea.
Yes, tricot staining definitely helps. Dr. Rupal, and again, who's the group medical director for Center for Sight Group of Hospitals based at Baroda, and a huge experience in refractive surgery. And she's going to be telling us how I plan PTK in different situations. On to you, Rupal.
Thank you, Chitra. Thanks for the invitation and thank you for holding such a great seminar. I'm going to be talking to everybody about phototherapeutic keratectomy, my 2 cents. It's the unique application of excimer laser for non-refractive purposes, and everybody who is doing refractive surgery should know this particular fantastic modality of treatment. The objectives of PTK are for removal or treatment of diseased corneal tissue in order to improve best corrected visual acuity, in order to alleviate visual symptoms such as monoocular diplopia, starburst, glare. Sometimes it's done for alleviation of non-visual symptoms such as pain, foreign body, or gritty sensation. And sometimes it's done simply to improve the cosmetic appearance of the eye. The rationale is that from the very beginning of the use of ophthalmic excimer laser, its clinical potential for removal of diseased corneal tissue was recognized. And it's because cornea has lamellar structure, it lends itself very well to the excision of diseased superficial tissue, leaving really a healthy cornea behind. Manual keratectomy is often unsatisfactory for all except the most superficial lesions because it can lead to scarring and opacities. Alternative is to include lamellar or penetrating keratoplasty. So if you need to compare PTK procedures with keratoplasty, it is simpler, faster, allows faster visual recovery, and does not have the risk of tissue rejection. Also, it saves this very valuable donor corneal tissue for more severe or intractable conditions. But the procedure is limited only to anterior cornea, and it also does not preclude future LK or PK, which is a big advantage. Excimer laser properties of removal of tissue with cornea, of the cornea layer by layer with great precision is what is making use in the PTK procedure. It does not cause any collateral damage due to the unaffected tissue, except because of the limitation of the beam profile. And re-epithelialization is really accelerated following excimer laser therapy. Also, it leaves behind absolutely smooth surface. It allows combination of refractive surgery along with removal of superficial corneal pathology, and has some kind of sterilizing properties, sometimes somehow involving denaturation of microorganisms. And therefore, there are a number of ways in which a PTK procedure can be applied to different disease conditions. The disadvantage of excimer laser is that inevitably, removal of anterior corneal tissue leads to a hyperopic shift. And if you don't use proper techniques, it can lead to, again, a great amount of anisometropia with no use of that vision gained. And therefore, you need to learn this procedure of smoothing, which I'll just delve into a little bit in a short while. And there are differential ablation rates for normal tissue and scar tissue, which could lead to unpleasant surgical surprises. And this also needs to be taken into account. There are different ways of classification of the PTK procedures. I will not go much into the detail for the want of time, but indications include recurrent corneal erosions, persistent epithelial defects following chemical injuries, and superficial dystrophies like map dot dystrophy. And it really depends on the proper and smooth removal of tissue, along with rapid re-epithelialization. We have found that sometimes recurrent erosions can be very difficult to treat. And this is one such case of intractable recurrent erosion. This person had repeated recurrent erosions, and this is 2 years post, where after the PTK procedure, where there was no erosion repetition at all. Here what you do is remove the diseased epithelial tissue and use your excimer laser on PTK mode in order to remove the diseased basement membrane. Also then take the excimer laser on a short mode and bombard the healthy epithelial tissue in the just beyond the denuded area, so that it acts as like an anterior stromal puncture. And then put a bandage contact lens, and you'll find that the recurrent erosions are gone forever. And I have now the longest follow-up of 25 years. So if you have to use it to remove diseased tissue, you have to be very careful because there are surgical challenges. There are areas of thinness exactly where the scars are, and they are not very easy to visualize under the laser microscope. And also it's difficult to monitor the endpoint. So you have to interrupt the treatment in order to get the correct outcome. And you should prevent hyperopic shifts and irregular astigmatism. So you need to smoothen out the scars. So basic tip is that you should choose cases where the dystrophy or scarring is within the first 100 microns of the cornea. The more anterior the problem, the better are the results. And most important is to use this correct technique. When you have a scar tissue, you'll have such irregularities in the cornea. Simply passing the excimer laser would actually mimic these same irregularities at a lower depth. But if you cover it with some solution, depending upon the irregularity, you can use right from balanced salt solution to sodium hyaluronate. And then you would find that the excimer laser first goes through the fluid, and as it keeps going, making more and more passes, the projecting irregularities along with the fluid starts getting ablated. Ultimately, when you go deep enough, you would have a very smooth surface remaining, and the scar also goes away. This is one such example of dystrophy where 2 weeks post PTK, you can have results like this. The uncorrected vision went from 624 to, and the best corrected vision was 69 with plus 2.5 diopters. OCT comparison, you can make out that the scar, the tissue has become, cornea has become clear. This is another such case where you can see how nice and fresh looking the cornea is after the PTK procedure. PTKs are also used for removal of pathological tissues, where there are scar tissues in anterior stoma, pterygium, tumors, and melanoma, bad-shaped corneal keratopathy, and so on and so forth. You have to remember that limitation of the depth of involvement which can be treated is only to the superficial 100 microns or so. You have to remember that the most areas around the scar are quite thin, so there are high risk of perforation. High hyperopic shifts if you're going to go very deep. And in case the thickness of the scar is more than 100 microns, then penetrating keratoplasty is definitely a better option. And so there are a number of such indications. One very good indication is to prevent recurrence in cases of pterygium, along with removal of the scar tissue, which is invariably left behind if you have recurrent pterygiums which go to different levels in the cornea. This is one such example, and you can see there is no other way that you can get such bright and normal looking cornea after such a recurrent pterygium, and pterygium to this extent. These are the surgical steps. You remove the pterygium, smoothen out the bed, allow reepithelialization, and you would find that you have a cornea without a scar. As regards removal of tumor, it helps to precisely remove the tumor. This is one example of conjunctival SCC, squamous cell carcinoma, and you also can prevent recurrence by doing such a procedure to a great extent. As regards band-shaped keratopathy, it again works very well because it's a superficial lesion. They may come back, but at least it gives a very good period of a good vision. Dense corneal plaques like this can be removed very easily. And you can also use PTK for correction of iatrogenically induced problems, where you have decentered ablations, where you have smaller zones, and which can lead to a lot of visual symptoms. You can use PTK in order to, in a way where you can increase the zone size and also smoothen out whatever are the irregularities. This is one such topo-guided treatment example. And I thank you all for your kind attention.
Thanks, Rupal. You really extensively covered it all, and I think the only thing you may not have included is even in when you're doing cross-linking, you could even come do a PTK and then go ahead and cross-link after measuring thickness. And I think that was the simplest of the ones. Wonderful presentation. I'm not going to take questions. I'm going to go on to our next three speakers who I'm really sorry about the delay which I've done this time. And Mr. Dr. Anand, please look at the time which we should have done from the beginning, including discussions. We have our next eminent speaker, Dr. Sudhir, who has actually probably come the first time in my webinar and somehow got missed each time. And he's a senior consultant, cataract, cornea, and refractive surgery, and heading the Department of Preventive Ophthalmology, and also head of the Health Informatics. And we really know what an immense help he is for the very popular EMR systems which they have at Shankar Nethralaya. And he is going to tell us how I manage PRK haze.
Thank you, ma'am, for the invitation and for this presentation. Am I audible?
Yes, yes.
Yeah. I'll be talking about the post-PRK haze, which is again a problem which we face when we start doing PRK for higher powers. So to look at the definition is the loss of corneal clarity after refractive surgery leading to decrease in vision. You can also have a myopic regression and irregular astigmatism. Etopathology and predisposing factors are poorly understood, but haze is due to abnormal collagen deposition and decreased corneal refractivity. Most cases of post-PRK haze are clinically insignificant and self-resolving, and incidences of significant PRK haze is only 3 to 4% at 6 months. So in vitro and in vivo studies focus on modulation of TGF-beta pathways, inflammation, and extracellular matrix remodeling. Clinically, looking at the risk factors, high refractive error whenever you're doing more than 6 diopters, higher ablation depth greater than 80 microns, smaller ablation zone, and exposure to UV post PRK. And it also depends on the methods of epithelial removal. If patient, if preoperatively they had a clinical intolerance, altered tear breakup time, had meibomian gland dysfunction, and vitamin D levels, these are the patients who are predisposed to PRK haze. The group from Narayan Nethralaya presented the risk scoring system for post-PRK haze, and based on the various contact lens intolerance, tear breakup time, the gland dropout, OSDI, and vitamin D, they graded them into low, moderate, and high risk. And this helps in predicting and controlling these risk factors before the treatment itself. And to grade the haze post-PRK, it's very simple to look at the haze, whether they're able to see the structures behind. There's no haze, completely clear cornea, 0.5% trace haze seen with careful oblique illumination, and very severe haze where complete opacification of stroma in the area of the scar, and anterior chamber is totally obscure. So most commonly we see in post-RKs when PRK was done. Pathophysiology of post-PRK haze is very simple. Whenever there is a disruption of basement membrane by laser, the central keratocytes apoptosis occurs and the peripheral keratocytes migrate to the center. And these transformation of these keratocytes to active weighted fibroblasts are responsible for these converting them into myofibroblasts. Most commonly, physiologically, they get apoptosis, but if there is a abnormal, then they start secreting irregular ECM proteins, and that is responsible for the haze. I'll take you through 3 cases where how we managed it. This was one of the patients who presented at 36 years with blurring of visions for more than 2 years. PRK was done elsewhere 6 years ago. Patient had hyperthyroidism. On the right eye, patient vision was 6/45, whereas in the left eye was 6/7.5. Refraction was irregular, and whereas in the left eye was clear, and the patient had good vision. On examination, we saw a reticular haze in PRK, almost grade 2 in the right eye, whereas the left eye was normal, and there was abnormal topography because of the PRK. So as we all looked at the various methods of looking at PRK haze, one need to look at sclerotic scatter, or to look at retroillumination. That will help us in identifying the area of haze, and we can also do it in OCT, or we can to identify the layer and how much is the haze there. So in this, we had the management plan was to go ahead with PTK with mitomycin. We also gave the patient a contact lens trial, but with the contact lens, the patient improved to 6/6, and patient wanted to go ahead with contact lens and did not come back for. So there is an option of irregular astigmatism when patient were not willing to go for treatment. Still, we can go ahead with the contact lens and medication with lubricants. There was a second patient which also presented, who was a 31-year-old female who presented to us with blurring of vision for 6 months. PRK was done 10 months back, and in the right eye was 6/9, whereas the left eye, the vision was 3/60, and you can see the regression of almost -4.5. And in the right eye, there was a mild moderate reticular haze, whereas in the left eye, it was like a honeycomb haze. So again, you can use the densitometry to identify the haze and the severity of haze. We can also use it for serially following up whether it is improving or worsening. So in this, we offer the patient to go for a mitomycin C with a PTK. Mitomycin is generally used as a prophylaxis in all cases of PRK. So that it's an alkylating agent and delays prevent corneal deposits and induce keratocyte apoptosis. Whereas the PTK removes, as Dr. Rupal Shah Madam has clearly explained about the various options of PTK. So we can combine PTK with mitomycin, which will help in minimizing the completely removing the haze, and also with the mitomycin you can prevent the recurrence. So it is minimally invasive, safe, effective, and delays recurrence. It avoids in a bad cases like ALTK. So in this case, again, we did a refraction. Patient's vision with the left eye did improve. We did a PTK with mitomycin. Again, we did in a stepwise manner. The first shots were about 50 microns. Then we tried up to 40 microns, where the 40 micron shots were split into 20 microns each. So we can actually look and see how much the haze clears up. So based on that, we can increase the number of shots even at the steps of 10 microns. Post PTK, this patient had completely, the haze has completely disappeared. So you can see pre-PTK, the haze, which was like honeycomb appearance. Post treatment, this was completely cleared and the patient improved vision to 6/6. So pearls to manage post PRK hazes: careful pre-op evaluation, which is very important. treatment of modifiable risk factors like dry eye, MGD, perfect fitting and comfort of post-op contact lens, which is crucial for epithelial healing following PRK. Instructing the patient not to overuse anesthetic drugs, because some of the patients, to prevent pain, they start using without our knowledge anesthetic drops. Cooling the cornea before and after ablation. The most important 2 cents for me is the mitomycin, which we need to use in all PRK patients, and we follow the regimen of every 10 seconds per diopter correction in patients more than 2 diopters of refractive error. And we have been doing PRK for almost so many years, and the number of cases which we had was almost like 4-5. Most of the times the patients are referred from outside. To conclude, haze post-operatively should be graded, documented both subjectively and objectively with pentacam and OCT. PRK haze of grade less than 2 requires only observation. For advanced stages, more aggressive treatment is necessary. MMC can adequately prevent and also treat haze after refractive surgery. PTK with MMC is helpful in advanced cases. Thank you.
Thank you very much, Dr. Sudhir. Maybe these are also cases wherein you could look at I have no experience on doing a topo-guided regularization also, if it is feasible, depending on the depth of the scar, because of the irregularity which comes up with it. I'm truly not clear on that. Any thoughts? And
we have not done irregularity, probably. We didn't have any experience, but I think yes, we can look into it. Topo-guided treatment, but I think the first step is the PTK, and if it doesn't clear up, maybe in the second stage we can look into the topo-guided treatment.
Yeah. Thank you very much, Dr. Sudhir. We shall now go on to our next speaker, Dr. Jeevan Titiyal, and who's going to tell us an extreme scenario, and I'm sure he has an excellent set of videos to drive home when you would do this extreme step, losing flaps. On to you, Dr. Titiyal.
Yeah, thank you very much, Dr. Chitra, for a kind invitation. And most of the things have been covered very nicely by previous speakers. Very few things to highlight from my side. Yes, there can be a very extreme scenario for where we can lose the flap in the scenarios which can be intraoperative, where we discuss about the free cap, buttonhole in the flap. Sometimes flap laceration can happen. As far as buttonhole is concerned, it's very, very rare. In fact, now microkeratome use is so less, we hardly see these very difficult complications, which may be less than 0.4% now. The main risk factor I would understand is excessively a steep keratometry, which is going to be some sort of risk factor in these cases. As soon as you see a buttonhole, if you are sure that you have buttonholes, should not lift the flap in these scenarios. If you have some sort of irregular alignment of the buttonhole, then you might lift it, irrigate the interface, and put it back again for a proper alignment. These cases should be seen after 3 months, and make sure the refractive stabilization is there before you attend for a resurgery in these cases. Other extreme scenario where you can lose flap is a free cap, and most often we have been practicing when we used to do microkeratome surgeries, normally make 2 radial marks in the cornea so that you can align the flap appropriately in those cases. That would be helpful in our cases with a free cap also, and you can align the flap accurately. The important risk factor is mainly 2. One is inadequate suction happening because of various anatomical factors. The second important may be a flat keratometry. So this just opposite to buttonhole happening in the flap in these cases. Once you have free flap, it's important to realize the size of optical zone and the free flap in these cases. If your flap is larger than the optical zone, there you can ablate the cornea. And if you have successfully retrieved the free cap, you can position onto the surface. If you have previously marked, you can align very, very nicely and wait for at least 3 to 5 minutes for it to get attached because of endothelial function. Very rarely you might need suturing or using a glue in these cases. More often it gets attached very nicely. Put a contact lens. Don't be in haste to remove contact lens in these patients. Maybe you can put it for at least 1 to 2 weeks. It's very important to examine these patients after 20 minutes to see that the cap is well attached in this case. So this is a scenario where if you have a mark here, you can always align these flaps. Sometimes there will be some difficulty, which is epithelial side or stromal side, but with a high magnification, you can see very clearly in these patients. I think the important scenario will come in the post-operative phase. There are two important segments. One is infectious, and second, a non-infectious category. So we all know infectious category is difficult. Sometimes we have to make a decision right on a time to decide what would be the actual time for us sacrificing the flap. Previously, we used to maintain the flap, try to lift the flap, scrape it, and treat. We all came to understand that interface infections are very difficult to manage. So it is to decide when actually we're going to amputate the flap in these cases. So we had this patient, I think one of the early cases, where the infectious keratitis happening in the interface. Slowly the flap melted out, and ultimately we had to sacrifice the flap, in fact the entire cornea, to do a therapeutic graft in these patients. So this is another patient had undergone microkeratome assisted LASIK outside, came with a small area of infection which became larger. Then I had to do a deep antilaminar keratoplasty, which remained clear for 6 weeks. And again, the infection came back, and ultimately we had to sacrifice the cornea to do therapeutic graft. So these two important cases make us realize that if you take a decision, appropriate time to amputate the flap, you can treat the infection very nicely and save the eye in these cases. Other concern will be the traumatic flap dislocation, which happens in a LASIK cases. Even after many, many years, you can have a dislocation happening in these cases. This is one of our patients where had a flap because of dislocation. It's identified by the area of clear stroma visible from the flap edge. And it depends at the time of flap dislocation, less than 1 week or more than 1 week. You can manage this patient according to a time frame. Always, as we discussed, the documentation has to be proper, assess the flap quality, do anti-segmental OCT in these cases, and subsequently treat in these cases. I would like to show one case where we recently reported this case in a COVID time. The flap got dislocated because of a mask, the face mask hitting the flap edge in these cases. So this was a case, second day post-op, you can see entire flap got dislocated upwards. The identification factor is, in these cases, we saw the Dr. Sujata showing that flap folds, which are normally radiating from the hinge area, but in this traumatic dislocation or disruption, the folds are horizontally placed in most of the cases. If you see here, this is the dislocation happening in these cases. This is a clear stroma, and this is the edge of a flap. So most of the time, it will get epithelialized within 24 hours also. So even you have a flap striae or dislocation happening, you have to remove the epithelium, and this horizontal fold is very difficult to manage sometimes. And it's very important, as Dr. Mahipal talked about, you need to dilate the eye. You can see better with the retroillumination. I have not lifted the flap. Without lifting the flap, I could took out these horizontal folds in these cases. It should take some time to make sure you do ironing in a proper manner. And this is the immediate post-op next day, nicely up post flap and 6/6 vision subsequently. And people can read this case report in IGO. Other extreme situation will be where you have first flap dislocation happening. Patient did not report for more than a year. And at that time, you can see vision has gone down to 4/60, best corrected 6/36. And the refractive error seems to be better. But if you see this patient had a total fibrous dislocated flap with a large epithelial ingrowth, and which would not make this flap viable even after you try to deposit this flap subsequently. So we did the topography. You can see totally irregular cornea with irregularly thickened fibrous flap in these cases. So we did a IOCT guided removal of flap, and subsequently taking care of interface also, where is a large area of epithelial ingrowth, which would require a treatment subsequently. So once we could identify the area, as I said, we removed the epithelium first. In these cases, it is important to remove epithelium from the area of clear bare stroma also, because it's a long standing and there will be a thick epithelium in those areas also. Once we could get a cleavage, I had to amputate because this was almost half of a flap is visible. The entire other half of flap was not there. So we removed this flap. Along with this, the entire epithelial ingrowth also came out. And this, you can see that such a fibrous flap which cannot be retained. So we had to amputate this. Subsequently, this area was massaged out, all the epithelial cells. And I used, as we discussed regarding use of alcohol or mitomycin C. In fact, in this particular case, because it was a long-standing pathology, we used both mitomycin C and alcohol in this person, 20% alcohol. And subsequently, this patient, we followed up for a period of 1 month, 1 year. And you can see that surprisingly, vision came down to improve to 6-9 parts uncorrected and 6-6 corrected vision. And you can see corneal thickness looking quite all right and bandage contact lens. This is day 1. And after 1 year also, if you see the topography, this was a pre-op topography, totally irregular. And this is a post-op topography, looks quite smooth. You can see cornea is now better, though there's a cylinder is there. And this patient will improve. So sometimes we do have to sacrifice these flaps also, despite being a chronically long time epithelialization happening in these cases. So another area which I like to highlight, this will be concern when you have extreme ectasia, when your bed thickness is less than 200 microns. We had described the technique of flap replacement surgery. Remove the LASIK flap, complete the circle with your dissection, make a little pocket in the periphery, and put a full thickness graft after removing the endothelium and put a multiple sutures. We described 2 cases way back in 2010 in British Journal. And this is a good technique for extreme ectasia where you can just peel off the flap and replace with the graft. You have a very nice, smooth LASIK flap in these cases. To summarize, I think extreme of losing flap is very rare situation in LASIK surgery. Intraoperatively, free cap may be one situation where you lose the cap in between the keratome head and you don't have any other options. There you have to wait and let the cornea heal and then plan accordingly, maybe PRK in those cases. Sometimes keratitis may be a cause for losing the flap and requiring a therapeutic graft sometimes. But most importantly, the traumatic flap dislocation is the one where the very nicely done surgery can get totally disrupted with the flap getting totally organized, disorganized because of fibrosis. And normally all these cases will have a epithelial ingrowth also associated, and you may have to sacrifice flap in those cases also. So if you examine these patients at right time, if the patient reports back immediately after the trauma, we can salvage the flap in those cases. If they come late, then you may have to sacrifice the flap. Thank you for kind listening, and thank you again, Chitra, for giving this opportunity.
Wonderful talk, Dr. Epithelial, and amazing videos. We've also had just one experience. We had a range of experience, but how has the residual error evolved? As you said, in our case also the residual error was less. But has it ever been that you have needed a scleral contact lenses later for the irregular cornea, which remained at the end of it, or any such?
Put your video on, Chitra.
Yeah.
In this particular case, like we didn't try a sort of a PTK to smoothen the surface, which should have been we should have done. But luckily, after removing the flap, patient did very well. Now it is 1 year post flap sacrifice. He's doing quite all right, and he has some cylinder. Maybe we can plan a contact lens for that cylinder subsequently. You rightly pointed out, correct.
Thank you, Dr. Epithelial. We shall go on to our last speaker, and of course, Dr. Mars is a young consultant from Center for Sight Group of Hospitals and has a very good experience in refractive surgery. And all of us look forward to hearing your talk, how I would approach suction loss in SMILE. On to you, Dr. Mars. Are you muted?
Good evening, ma'am. Hope I'm audible.
Yes, yes.
Yeah, thank you, ma'am, for giving me an opportunity to speak. And I will be short because I'm the only thing standing between everyone and the dinner here, I understand. So how would I approach suction loss in SMILE? So basically, coming to the basics of SMILE surgery, what is done in SMILE is that you have basically 4 cuts here. The first cut is attached to the laser optical lenticular cut, and then a lenticular side cut, and then a flap cut and a flap side cut. So you can have a suction loss during any of these stages. Let us see how we manage each one of those. The surgical videos shown here are mine and Dr. Rupal's. So in this first scenario, if you see, we have docked the cornea, initiated the suction, and once the lenticular cut has started, we see that the patient has squeezed his eye. On squeezing of his eye, we see a suction loss. So the first cut here is not completed. Now, what do? The machine goes into something called a repair mode, and this repair software is incorporated in the VisuMax. So here, we use the uncut area to center it again and convert this cut into a flap. Now here we are initiating the suction again and doing a femto flap procedure, which is about 2 millimeters more than what the intended lenticular cut was. So here you would see that the spiral out to in cut is being done, and now you are converting the SMILE into a flap. So under the microscope, you would see something like this, and then you would raise the flap and complete your excimer laser correction from here. So this patient had a suction loss, but eventually it was converted to a femto flap, and we had a very good outcome in the post-operative period. Now let us see a second scenario. Now here a schematic representation of this. What was done was that an incomplete cut is shown in the red color and the repair cut is shown in the green color. So you had an incomplete cut and a repair cut as a femto flap. In a second scenario here, you have again initiated a suction, an outside in cut is being created. The first cut is over, then you have the lenticular side cut, and if you observe in the center, as soon as the flap cut was starting, the patient started squeezing his eye, and ultimately the suction was lost. So we have the first cut done and the second completed, but at the third stage we had a loss of suction. Now how we would approach this is, again, the machine is going into the repair mode, and here just a flap is being cut, the flap and the flap side cut. Now this will again proceed like how a regular SMILE surgery would. A schematic appearance of this surgery done is that first cut, that is in orange color, is the lenticular cut and then the lenticular side cut. Then if you see in the red color, it was an incomplete cut of the flap where we had the suction loss. So there we did a repair cut which is green in color and which was about 0.2 millimeters less than what the intended cut was. We will discuss that later. Now let us see a third scenario here where again suction is applied and then you have your first cut being done, that is the lenticular cut, then you have the lenticular side cut, then you have the anterior, that is the flap cut, and then the patient squeezes. So you have all the cuts created except for the flap side cut. In this scenario, you have a little haze, so you switch on the UV light and then you see this clearly with a good centration. All you need to do is just create a flap side cut 0.2 millimeters inner to what was actually planned. So you don't do anything except a cut, and then you have your SMILE surgery progressing. So this is a schematic representation of how this surgery was managed. The orange cuts are the complete cuts, that is the posterior lenticular cut, the vertical cuts, the flap cut, and only when we were doing the side cut we had the suction loss, and it was adequately managed by just using a flap side cut. So how would you prevent such scenarios? Most important is that you have a short speculum to suction initiation time. Now this comes with experience. If your time taken to initiate the suction after putting the speculum is longer, the patient tends to squeeze more. Nowadays, everyone uses a fast mode of treatment. A standard mode of treatment should be avoided. A fast mode of treatment typically takes about 22 to 25 seconds. The pre-op docking should be soft, and there should not be any fluid in the area between the cornea and the cap. The third is verbal anesthesia. As someone who has been under both the sides of the microscope, as a surgeon doing a surgery and also someone who has undergone a smile surgery, my experience is that you can see the fixation light very well, but once the first cut is over, the fixation light is not seen. At this time, the patient panics and tries to squeeze much. So during this time, it is always better that you give a reverse countdown to the patient saying that you have 15 seconds remaining and 10 seconds remaining and calm him. Most commonly, suction losses are associated with anxious patients. So to summarize, if you would have a suction loss at the stage of the first cut, that is the lenticular cut, it's better to convert it into a femtolasic. If you would have it at the second stage, that is the lenticular side cut, decrease the lenticular diameter by 0.2 millimeters and then complete the surgery. If you would have it at the stage of the cap cut, as we have seen in the video, redock and repeat the cap cut. If you have it at the stage of cap side cut, as we have seen now, redock and do only the cap side cut. And eventually, if managed properly, all patients have excellent outcomes, even with suction loss during relaxed smile, which I should add is a little more common because the pressure exerted by the Visumax laser while creating the lenticule is just 35 millimeters of mercury. Thank you all for your patient hearing. Thank you everyone, and I thank Dr. Rupal Shah in particular for giving me some of the videos. Some of the videos are mine and some are hers. Thank you everyone.
Thank you, Dr. Mars. That was a very explicitly discussed topic. I have one question for the expert panel. Can you stop sharing your screen?
Yes.
Before we conclude, I have a question here. Supposing the OBL was primarily not well centered and then you had a suction loss, how would you center the repeat dock? Dr. Gaurav, are you there?
Yeah. So I think we've had an amazing session, but so I would probably, invariably, if you did not have that, it becomes a little challenging, especially if you kind of spend time in between. I would usually when you ask the patient to fixate on the green light, and typically it will center properly, and unless you had a previous suction where the patient was not really well centered on the fixation light, only then this kind of a situation would arise. So usually this has in my hands, it's not been a problem. Whenever on the rare occasions I have had a suction, but if you want to add anything else, it would be nice.
Yeah,
I would suggest switching on the infrared camera would be a very good option because that would help you to see your pupillary margin more clearly and proceed with this with the surgery.
Sometimes it says that the treatment is complete, but you had a suction loss right at the end with the conjunctiva prolapsing in the last run. So what is the challenge at that point of time? That incision doesn't get cut, no? Then you'll have to manually open up the incision in that.
There is a very good paper by Dr. Gitansha regarding this. There's a case series of 3 cases which she has presented in the JCRS, where just anteriorly, that is 0.2 millimeters, she has just used a simple surgical blade and she has made a vertical cut and she has gone in and removed this. That could be one option if you just need to do a side cut. I think that's in JCRS. It's fairly recent, 2001, Dr. Gitansha's paper.
Actually, that's a way to salvage the condition, but one way of avoiding it is once you see the conjunctiva creeping in, you have to stop the laser. And then you have to reposition the eye, redock, and then complete the treatment.
Absolutely.
There were a number of questions which were left, but anyway, I think it has been really a great set of talks, and every talk there was so much of information and very gainful. So my very, very special thanks to the expert panel for being there, and I'm sure they learned as much as I learned in this particular webinar. And thank you to every single speaker who did great justice. And even though I think it was some delay in too much of discussions in the earlier parts, which delayed the whole process, but there has been a lot of learning. My special thanks to Mr. Kripal and the AIOS team for being there always for us. Our thanks are very, very much due to Dr. Anand Sethi and his webinar team. Only thing this time we should have checked on the timing, so this was again a lapse, mutual mistake. And of course, thanks to Sai and the Numerotech. And most importantly, I need to thank deep felt thanks to the Endo team for having been steadfast and supporting us in all our ventures. My thanks are always, always due to my very efficient ARC team, and I think we should have fewer number of talks and more discussions in the future. Otherwise, I really could have gained more from Anagha's thoughts and Satyajit's thoughts in this interesting webinar. And finally, I think all of us owe our thanks to our attendees who have learned and watched, and the attendance has been pretty decent, pretty good, nearly over 400 of them, and I think more would watch over the days to come. And thank you one and all. Thank you so much. Thank you.
Thank you, Chitra, for starting this season. Season, what season is it now? Season
3 with a very refractive webinar, no?
Yeah.
So much of information.
Thank you
Dr.
so much.
Chitra's Netflix. Yeah. But amazing talks. I mean, I learned so much, and each talk was like so amazing. Thank you so much.
Thank you.
Really enjoyed. I couldn't leave it. I was planning to leave around 8 o'clock, but I didn't leave because it was so good.
Hope we have it in the physical mode the next time.
Yeah. Physical mode, we will not have such cream of surgeons talking, It's difficult. Anyway, thank you so much.
Thank you.
Thank you.
Thanks, Chitra.
Thank you.
Thank you.
Thank you, everyone. Good night. Thank you, everyone.
Thank you.